Good morning and half a day. The Committee on General Government Operation and Appropriations is now called to order. Today is Wednesday, July 12th, and the time now is 9:11. Apologize for being late. In compliance with open government law, the notice for this public hearing were posted on the Gov Guam Public Notice Portal, KGTF PBS Channel 12, and disseminated via email to all senators and all main media broadcasting outlets on Monday, July 3rd, and then on Friday, July 11th. The agenda this morning is Bill 26-37 COR, Committee on Rules by request of I Magaʹhågan Guåhan, the Governor of Guam, in accordance with the Organic Act of Guam, an act making appropriation for the operation of the executive branch of the Governor of Guam for fiscal year ending September 30th, 2024, making other appropriations and establishing miscellaneous administrative provisions relative to the Guam Memorial Authority. At this time, I ask the members of the Guam Memorial Hospital Authority panel to please rise and be placed under oath by the Sergeant Arms.
Please raise your right hand. Under penalty of perjury, do you all affirm that any and all information you provide today, whether it be verbally, electronically, and in writing, be the truth, the whole truth, and nothing but the truth? Mr. Chair, under oath, you may proceed. Thank you.
Thank you, Sergeant Arms. The rules of this budget hearing are: please provide my legislative staff with any document for photocopy and distribution. Panel members are asked to remain in the room for questions or for additional testimonies may be desired by members of the committee. Questions and testimonies shall be confined to the substance or nature of the agenda. Personal inference as to the character or the motive of any senator or any individual testifying is not permitted. Any violation of the general rule of conduct will result in removal from the budget hearing. Proper form and decorum shall be practiced by all present in the public hearing room. For this proceeding, individuals who fail to maintain proper form and decorum will be restricted from participating and will be removed from the room. When you speak, please make sure that the microphone is on and that you speak into the microphone. Please state your name and your title for the record. I'd like to acknowledge my colleagues that are here this morning. I begin with my Vice Chair, Senator Tello Tairigui, and the Oversight Chair for Guam Memorial Hospital, Speaker Therese Terlai. We have Senator Roy Cananta, I did see him. Senator Chris Duenas, we have Senator Jesse Luan, and Senator Tom Fisher. And I ask now Ms. Rapadas to give her opening.
Okay, thank you. Buenas and half a day, Senator Joseph Agustin, Chairman of the Committee on General Government Operations, Appropriations, and Housing. Speaker Therese Terlai, Senator Tom Fisher, Senator Jesse Luan, Senator Chris Duenas, and Senator Roy Cananta. On behalf of the Board of Trustees, management, medical staff, employees, and the patients we serve, we extend our gratitude for giving us this opportunity to explain, justify, and validate the hospital's fiscal year 2024 budget. With me this morning are some of the Executive Leadership and Management Council members. To my far right is Dr. Dustin Prince. He is the Associate Administrator of Clinical Services. To my immediate right is Mr. William Kando, Associate Administrator of Operations. And to my left is Ms. Yuka Hichinova. She is our Chief Financial Officer. Not all of our executive leadership are physically here, but I'd like to recognize them as they contribute deliberatively to the effectiveness and efficiency of the hospital's operations. Thank you. That's Danielle Manglonia. She's the Administrator of Quality, Patient Safety, and Regulatory Compliance. Dr. Vincent Duenas, he is the SNF Medical Director. Ms. Pauline Lizama, she is a DOC Hospital Nursing Supervisor for the on-site clinics at the Manila and the Hagåtña clinics. Ms. Bel Rada, she is the Assistant Administrator of Professional Services. Ms. Christine Tucaro, Assistant Administrator of Nursing Services. Ms. Lizelle Concepcion, she is the Deputy Assistant of Nursing Services. And Mr. Jeffrey Ventura, he is the Deputy Assistant of Operations. Now, if I may, Senators, I want to make it abundantly clear without sounding loquacious and redundant. GMHA, as Guam's only public hospital, is a safety net hospital. What this means is that GMHA has a legal obligation and responsibility to provide health care for and to all individuals, regardless of their insurance status or ability to pay. This legal mandate requires GMHA to serve all populations. GMHA is the go-to public hospital for Guam, and it is the only hospital that serves the maternal child health, that's the MCH population. We are it. I know you all know this, but I just want to make sure I articulate and reiterate this fact as emphatically as possible. If we cannot provide or sustain basic medical care to everyone who enters the hospital because of the limited resources, be it financial, staffing, or supplies, then we all fail in our duties and responsibilities, and we run the risk of closing the hospital, which we all hope we do not get to that point. Therefore, we humbly ask this legislative leadership within its appropriation authority and role to support the financial subsidy we need to keep the hospital operational. I also want to emphasize and reiterate that GMHA does not get 100% reimbursement by the different payers. And there's empirical evidence across the nation that payers pay hospitals, they reimburse hospitals, underpaying them and denying the claims that are provided. So we see that all the time here on our island. And so I'd like to start our budget request presentation by setting the landscape in terms of where we were based on our fiscal year 2022 budget, where we are now with our current fiscal year 2023 budget, and where we're headed to, what our vision is with our proposed fiscal year 2024 budgetary needs, not only to continue, but to enhance and improve the hospital's effectiveness, efficiency, and quality-driven services. So some of the highlights in fiscal year 2022, we rolled out the fiscal year 2022 with a budget request of $140.9 million, but our actual expenditure was $188.2 million. And Yuka will show that in their slides further, and I think you have copies of that with you, so you have that available. Total billings during that year on collections, we billed $253 million. We only collected $116.1 million. So only 46% is what our collection rate is. During that year, our total COVID census was 2,100, and of the 2,100, we admitted 792 individuals with COVID diagnosis. And then those individuals that were seen in ER, 853 were discharged home. 455 individuals with COVID were given the outpatient intravenous therapy regimen so that they did not need to be admitted into the hospital. Total number of employees who tested COVID positive that year was 760. In terms of patients admitted into the emergency room, 16,761 we saw in the emergency room and were treated. Number of deliveries for that year, 2,046. In terms of surgeries that we did, elective surgeries, we did 1,234. Emergency surgeries, we did 1,143. And I know you're going to ask me some questions about personnel, so I'll get to that later with more details with regards to our FTEs and total number of employees we have. Where we are right now with fiscal year 2023, we requested for a budget of $165.3 million. Current expenditure right now is $121.1 million. That's unaudited as of May 31st, 2023. In terms of COVID, I know COVID is over, the pandemic is over, but it's still in the air. So we continue to see individuals coming through the emergency room with COVID positive test results and with symptoms. And some of them get admitted, some of them whose symptoms are not that critically bad, so they get discharged home. For this year, to present, from October 1 to present, total COVID positive patients, we've seen 376. Of that, I'm sorry, I don't have the number of admissions. Total positive employees, 204. Through ER in the emergency room, a total number of individuals that came in, 12,065, and that's just up to May. So again, we're close already to the total number of emergency admissions for fiscal year 2022, and we're not yet done with the fiscal year. We launched our new electronic health record, that's with CareView. We launched it in October 2022. We renewed our CMS conditional participation certification. The last on-site survey was April 21, 2023, which the Medicare accepted our plan of corrective action, and so therefore we are recertified with CMS, and we will continue to receive Medicare, Medicaid funding. We are scheduled for our CIHQ, that is the Center for Improvement on Healthcare Quality. That is the accrediting organization that our Board of Trustees selected for us to then pursue accreditation, national accreditation. We're scheduled for that mock survey August 8th through the 10th, which is just next month. And then we finalized our 5-year strategic plan for calendar year 2023 to 2027. In that, we included a 5-year capital improvement plan, which Mr. Kando will expound further as we go on. And if you have any questions, we're here to answer those questions. What our vision is for the next fiscal year with 2024, basing on our new vision statement at Guam Memorial Hospital Authority, we will strive to improve the health and well-being of the people of Guam by providing advanced outpatient, inpatient, and post-acute care services. To accomplish this, we will partner with other health and care entities to improve the level of medical care on the island of Guam. We will strive to achieve and maintain financial viability, thus ensuring sufficient resources to fulfill our mission, and support our colleagues, these are our employees, our staff, by creating an environment where they experience dignity, joy, respect, and value in their work, and where they are empowered to achieve and maintain excellence. We will seek to maintain, renew CMS condition of participation certification, and that from the mock survey, we have 6 months to apply for the actual survey. So we're going to continue that momentum, that movement to then get and secure CIHQ accreditation. We will forge forward and strengthen the collaboration and engagement of community stakeholders to establish an intermediate care facility / transitional care facility for the 20+ individuals that we have in the hospital currently that we are taking care of, occupying acute care beds, but do not need to occupy an acute care bed. They really can be discharged home, but they have nowhere to go, no family to support them. So that's part of our challenges, is that we continue to care for these individuals who need to go home, who need to leave the hospital, who need to then free up that acute care bed so that we can admit those patients who come into the ER and are admitted to an inpatient unit, but we don't have a bed available, so they end up holding and waiting in the emergency room. Lately, we've been averaging about 20 of those individuals waiting in the emergency room for a bed. And so that's why we really need to push for those individuals to have, for us to have an intermediate care facility or transitional care facility so we can get them into that facility and free up those acute care beds. And that's challenging us to the tune of about $3 million a month that we're not getting reimbursed at all. $2 to $3 million a month, yes. We feed them, we give them medications, we give them a clean bed, but again, we don't get reimbursed for those services. We want to solidify our financial posture by enhancing and improving our billing, collections, and revenue processing systems. We want to add and expand outpatient clinic services. This will increase revenue generating opportunities. And we also want to enhance and expand our surgery department services. We're getting a new surgeon who's going to then provide such specialty services that's just not available. Soon it will be available on island. We want to reduce our dependence and reliance on off-island staffing solution resources such as travel nurses. I know you've all heard that. While they're great and they really help us out, it's costly. It's costing us to a tune of, was $50 million that we have paid for these travel nurses. Across the nation, hospitals are paying $500 million a year for these travel nurses. So it's quite costly, to put it into that perspective. With accreditation, we can leverage our efforts to pursue bringing medical students on board for their first-year medical school rotation and residency, which will expand our options to recruit physicians, especially those who are from our own island. A lot of our young people have gone off to become doctors, to get their education and training to become doctors. We want to bring them back. They are our people. We want to bring them back home. We want to obtain and secure the hospital's eligibility as a qualifying employer for the Public Service Loan Forgiveness Program, the 501c3 designation. At this time, we don't really have that. What we have is a territorial level designation. We need to seek a higher level so that these individuals can then get their loans to, in pursuing their medical education, get their loans forgiven or paid off by working for the government agency. We want to seek assistance, guidance, and support regarding the feasibility of attaining critical access hospital. That's a designation that will and can help us get a higher reimbursement from the CMS. And so before we continue, before we proceed to the details of our fiscal year 2024 budget request, I just want to again go over our new mission statement that we inscribed in our 5-year strategic plan. And I think you can go ahead and start the PowerPoint, because on that first page, right there, our mission statement is that Guam Memorial Hospital Authority is a public organization entrusted to improve the health and wellness of the people of Guam. We do this by providing an exceptional patient experience centered on quality-driven, safe, cost-effective healthcare services. So that's our new mission statement. The next slide, you will see where the departments that provide direct patient care, the divisions, those are where the nurse patients are admitted to, and that the nurses then, nursing and professional support, allied health professional support such as radiology, respiratory therapists, that's where they provide those services to the patients, direct patient care. And you see also at the bottom left, the DOC clinic, the mandate that we had in 2016, we established those on-site DOC clinics at the Hagåtña and the Manila facilities. Under the medical services, the anesthesia, employee health, infection control, the medical staff, we also have quality management under there. Informatics is a new department. It ties in with our information technology. And we also have telemedicine, we have guest relations, and we have the medical staff office. That's the office that processes all the credentialing of physicians or medical staff that are seeking privileges to admit and be consultants for the patients. Next slide, please. In the indirect patient care divisions, we have, again, the administration office with the support staff. We have FISCAL that is led and directed by our CFO, Ms. Yuka Hechanova. And we have also the operations that is led and directed by Mr. William Kando. So those are all the the departments that form the organization of GMHA. Next slide, please. I just wanted to share this, as a hospital, we are guided and we are required to follow many federal regulations, many codes, and many standards. And so these are the reasons why, our resources, our hospital staff, we need the staff to help us meet those regulatory requirements, standards, and codes. It's a big entity of regulations that we must know about, and we must adhere to, and we must comply, particularly the CMS. The Center for Medicare, Medicaid Services, that is the entity that reimburses us for Medicare, for individuals who are beneficiaries of the Medicare program or Medicaid program. They have many regulations that we have to adhere to. And the new accrediting organization, the CIHQ, they are deemed by CMS that they are aligned with the conditions of participation. So, it is really the right choice for us to pursue accreditation by this accrediting organization. And so now I'm going to hand it over to Ms. Yuka to go into the details of our budget request. Thank you.
Good morning, Senators. Thank you all for being here and listening to our testimony. We truly appreciate it. Next slide, please.
And your name?
Yuka Hechanova, Chief Financial Officer at GMH.
Thank you.
So this slide really summarizes our ask. We estimate our operating revenues at $124.3 million and $3.3 million from our DOC clinic. I've also included the executive budget request of $19.9 million from the pharmaceutical fund and $3.5 million from the general fund. We estimate about $500,000 right now for federal grants. So our projected revenues are at $151.5 million. Our projected operating expenses, however, are $193.8 million, and that leaves us with a shortfall of $42.2 million, which is our legislative ask this morning. Next slide, please. This slide just pretty much has most of the details of what I just explained. It breaks down the budget requests by the different divisions and also by the object classes. And at the bottom, it summarizes our funding sources, leading to the $42.2 million shortfall. Next slide, please. So this slide, I added just a handful of news articles that have been coming out in the last, I'll say, year or two about the financial viability and stability of many of the healthcare systems and hospitals across the nation. And so as the public health emergency ended in May of 2023, the pandemic has left GMH and other hospitals and health systems financially weaker. The American Hospital Association, Becker's Hospital Review, and other notable healthcare organizations report that hospitals across the nation faced the worst financial year in 2022, as half of U.S. hospitals experienced negative margins, mainly from the economic consequences of the COVID-19 pandemic, such as workforce shortages, supply chain disruptions, and other rising costs. Similarly, GMH faced tremendous pressure to recruit and retain critical staff to treat patients that are now sicker and stay longer in the hospital, and to manage cash flow amidst rising expenses. While many U.S. hospitals are resorting to closing and limiting services to alleviate these financial pressures, GMH continues to provide much-needed care to all patients, despite the tremendous growth in the costs of committing to and delivering this care. Even before the pandemic, GMH experienced staffing shortages, particularly in nursing and allied health. The pandemic caused significant shifts in labor markets. So what happened during the pandemic, many healthcare workers, it appears, just had this new outlook on the way they want to manage their careers, particularly with work-life balance. They were burning out. They were just rethinking a lot of things. So many healthcare workers had actually left the workforce, and that has really impacted a lot of us in healthcare. So a lot of them even retired, or they left for other reasons, to take care of their families even. So this leaves us with no choice but to pay for contract labor, such as travel nurses, who are expensive, to fill these gaps in critical healthcare staffing. In FY 2022, GMH employed up to 72 contract travel nurses in a month with hourly rates as high as $225 an hour. That rate has come down significantly right now since the pandemic is over. But since FY 2020, GMH has spent about $47 million for travel nurses, but we've only been reimbursed $24 million from FEMA, but we continue to diligently pursue federal grant reimbursement for these costs. But we really don't see much more funding from FEMA to cover the costs, and we will continue to use the travel nurses just because of the staffing shortages we are experiencing right now. There's also there's a lot of competition for nurses. They can pretty much pick and choose where they want to work. Compared to pre-pandemic FY 2019, overall personnel costs for FY 22 increased by about 25%. This was primarily from the nurse pay plan. We have the law enforcement pay plan and the many differential pays for our nurses, certain professional support staff, and technicians. GMH also implemented from April 2020 to January 2023 the COVID-19 response differential pay, which ranged from 10 to 25% for essential GMH employees supporting the public health emergency. Since FY 2020, the pandemic has had large impacts on costs. The historic rise in inflation has spurred a significant increase in GMH's non-labor expenses as well, such as pharmaceuticals, medical supplies, and even electricity. The implementation of our new HR has also caused an increase in software and hardware costs. High drug prices are a primary driver of rising pharmaceutical expenses in U.S. hospitals. It's been reported by the American Hospital Association that hospital drug expenses per patient have increased 20% between 2019 and 2022. Drug companies significantly raise prices of existing drugs and introduce new drugs at record prices. Medical supply prices have also been affected by ongoing supply chain disruptions, higher manufacturing costs, packaging costs, and shipping costs. Next slide, please. This just divides the budget by the divisions, and the blue areas represent the direct patient care areas, which account for 79% of the budget. 21% goes to the indirect patient care areas that Ms. Lillian described earlier. So a majority of our budget does go to direct patient care divisions. Next slide, please. And further dividing the personnel budget, we have 80% represented in the blue going to our direct patient care divisions and 20% of personnel cost in the green section for the non-indirect patient care areas. Next slide, please. So this will divide the budget by the division, and I just want to go over the areas that represent the most significant jump from our FY23 budget to the 2024. And so the first one is from professional support. We see a significant increase from FY23 to 24 by 10.3 million. And this is really for increased costs for our lab services. We have outsourced our lab services, and their costs have gone up dramatically. Newborn testing kits, we have to test all of the newborns, and the company that we buy the test kits from have had to raise their prices. Blood products, radiology supplies, respiratory supplies, even food costs have gone up, and we buy a lot of food to feed the patients, and pharmaceuticals as well, and the need for the travel nurses and contract staff in the professional support areas. The next area is under nursing, where we see a 5.7 million increase from last year's budget, and this is mostly for salaries and certification pay, differential pay, and of course the travel nurses. Next, in operations, we have increased costs for electricities, increased costs for computers, biomedical equipment and supplies. Laundry services are a critical component of our operations, and even just supplies for our facility repairs have gone up. And then finally, for medical services, we have an increase of $4 million, and that's mostly for costs for physicians, to hire physicians. Next slide, please. And then dividing it also by the object class, the highest jump, of course, is 16.5 million for salaries. And to break that down, we've estimated 9.5 million for the 22% GPP pay increases, $500,000 for law enforcement pay, the law enforcement pay plan, which we implemented this year, about $600,000 for increments, and $6 million for additional differentials and other special pays for nurses and clinicians. For supplies and materials, we also have an increased cost of 6.8 million. Of course, as I discussed earlier about the costs for pharmaceuticals, radiology, respiratory supplies, and oxygen. Oxygen has also increased in costs as well. And finally, in contractual, this is for physicians and travel nurses. Next slide, please. So just to kind of illustrate what I just described, for personnel, contractual, and supplies costs, since FY 2019, we can really see the spikes to current, especially on the personnel side. Next slide, please. So our gross revenues have grown, but it has slowed down this year due to the EHR transition and implementation. We have some issues we're still ironing out. The implementation for the EHR is estimated between 6 months and a year, and we just went live in October. We also had the network shut down in March, and that really significantly impacted revenues. So our corresponding billings have also gone down. However, the collections as a percentage of billings have increased to 53% compared to 46% in FY22 and 47% in FY 2021. So it seems we are collecting against the bills that we are getting out. The problem is we need to get more billings out as soon as we iron out all the nuances in the new EHR. Next slide, please. Our patient census is illustrated here, and it's almost to pre-pandemic levels. We're seeing tremendous growth in the emergency room. It's been very busy in the emergency room. From this graph, you'll see that the census dips after 2015, and that represents the time when GRMC opened. So that explains why the census had dropped. Next slide, please. In comparing our financial highlights across the years for May, so for May 2023 back to May 2020, you can see that cash is definitely decreasing through the years while our payables are going up. Revenues are lower this year than the same time last year, again, as I mentioned, due to our EHR implementation, which is still ongoing, and then our network shutdown, which had impacted our billings. So of course our collections are less than last year, but still higher than 2020 and 2021 levels. Our collections from Medicaid are much better this year, while our third-party payers are lower. Again, we're having some billing issues that are impacting the collections as well. There is definitely a domino effect happening here. Our operating expenses have decreased, mainly due to the lower hourly rates we pay now for the travel nurses, as well as the number of travel nurses. So we do not employ as much travel nurses as we did before, and I believe the rates right now have come down from $200 plus an hour to about $100 an hour. So it's translating to a much significant difference from the amounts we paid last year. Next slide, please. Comparing actual to budget, our operating revenues are 11% less than budget. Again, these are the impacts of the EHR and our network shutdown. We really rely a lot on our technology for billing and coding collections. Our grants are higher because we did receive FEMA reimbursement this year that we've been waiting for about a year, and that went towards the travel nurses. And personnel costs and contractual costs are also higher than budget based on the reasons that I explained earlier. We did implement the GPP this year as well. Next slide, please. And also the appropriations received in FY22 and 23 are actually less than amounts in FY 2020 and 21 by about $7 million. We did not get any appropriations from the Healthy Future funds as the prior year, and we do not get as much from the general fund as we did in the prior years as well. Next slide, please. This is our summary of the total COVID-19 related grants that we got as of May 2023 from various sources. The total is so far $75.3 million that we received. The $9 million that we got this year is mainly for the travel nurses that we received from FEMA. We don't expect any more COVID-related assistance to come because the pandemic has ended. Next slide, please. This represents our FY22 and 23 payer mix. The orange lines are our FY23 levels. So in FY 2023, we are seeing more self-pay patients moving to Medicaid. We have assisted uninsured patients with applications for Medicaid or MIP coverage through a collaboration with the Department of Public Health and Social Services. Most of our patients, as you can see from here, are actually covered by Medicaid or Medicare. The payer mix really explains our challenges with reimbursements from Medicaid and Medicare because we are limited to a per diem rate for our inpatient charges. So in FY 2022, our rate was $15.55 per day. So that's for an inpatient stay per day, regardless of charges incurred. So if the patient received a lot of diagnostical type treatments and medications and what have you, that may be, I don't know, for example, maybe $5,000 to $10,000, we're only going to get reimbursed the $1,500 from Medicare. With increases in labor and non-labor costs, this has a significant financial impact on GMH while we try to provide care for our patients. Next slide, please. As Lillian mentioned earlier, we have our new strategic plan for FY 2023 to 27, and for FY 2024 and 23, these are some of our strategic financial initiatives that we are implementing to help improve our cash flow. So we've already begun to clean up our receivables, and this is so we can better manage our outstanding claims and track them more efficiently. We will increase our room and board rates in FY 2024, and these rates are based on FY 2019 costs that we retrieved from that Medicare cost report. So we did not use our costs that were during the pandemic because we felt that it wouldn't be fair considering that the FY 2019 represented the period of pre-pandemic costs. And we are also taking a look across all areas where we can save costs by scheduling staff better to reduce overtime, repurposing even, and really reevaluating our needs. Next slide, please. And so I'll hand it over to William to talk about our capital improvement projects.
Good morning, Senators. My name is William Kando. I'm the Associate Administrator of Operations for the Guam Memorial Hospital Authority. Next slide, please. We've recently completed, dating back to the beginning of calendar year 22 to present, these are some of the CIPs that we've completed recently. The Emergency Department Canopy Upgrade project, that was in February of 2022. This is the area where the ambulance drops off patients at the emergency department. We completed the procurement of 12 very expensive total care ICU beds in March of 2022. The Z-Wing demolition, this is the majority of the Z-Wing that we demolished. This is called Phase 1 Alpha because we still have a small portion on the second floor that is still scheduled to be solicited and awarded, and we still need to demolish Phase 1B. That Phase 1 Alpha was completed in July of 2022. The ED trauma Sallyport construction phase, this is both actually on the trauma side and also on the triage side of the emergency department to enhance security. Bulletproofing for the security guard areas in case of things like a potential active shooter. The security guards are really the first notification of to rally the troops, and we want to protect them to make sure that we are able to bring in the troops to address any kind of issue like that. That was completed in May through July of 2022. We completed the installation and commissioning of 4 OR surgical lights in September of 2022. Air handling units is a major part of our improvements as we continue to implement the projects identified by the Army Corps of Engineers in late 2019. The air handling unit installs and commissionings, we've been doing them in sets of 7. So we completed the first set in July of 2022, another second set in in May of 2023, and the third set is actually ongoing. We've completed 3 of 7, and we have 4 remaining to be completed in September of 2023. We launched, as mentioned earlier, we launched the MedSphere CareView EHR system in October of 2022. The rooftop repair, roof coating, this is the structural and architectural packages. These have been completed as follows. We did the D-wing, which is above the laboratory, in April of 2023. The A-wing, which is really the largest section of our roof above our 4th floor surgical unit, in May of 2023. And actually this is the B and E wings in July of 2023. The B wing is above our 4th floor pediatrics unit, and the E wing is where our elevator shafts come up through our rooftop, actually situated between A and B wings. That is slated for completion actually this month. We still have more roof sections to complete. We still need to circle back on our C wing which is above our OB ward and our OR. So there's still small sections left that we still need to do, but this is really the majority, the greatest square footage of our roof sections that we've basically completed. We have completed the laboratory rooftop upgrade mechanical package. So it's both architectural, which is roof coating, repair of the roof cracks, and then roof coating, and then mechanical is really the HVAC components on top of the roof that needed to be replaced. These are also components that were allowing water infiltration, seepage into the facility because they were just so corroded. So laboratory rooftop upgrades completed in May of 2023. Main electrical distribution panel and sub-panels, we have ongoing maintenance. Actually, this year we've increased our MOU with GPA has been increased to actually quarterly maintenance passes on our main panel and sub-panels. So we completed maintenance passes in January, March, and then we're doing it also in this month of July. Alternate care site, we've procured quite a bit of medical equipment, a big package of about $2.8 million that is about to be reimbursed by FEMA so that to support the alternate care site at our skilled nursing facility under a non-acute care model. This was demonstrated to be very critical for COVID and other responses to all hazards. It allows us to decompress the hospital so that we can transfer low acute or non-acute patients to the SNF and allow us to continue to respond to any given major hazard like emerging infectious diseases. Emergency repair of our chiller number 2 was just completed this past month, late June. This was as a result of power fluctuations that occurred post Typhoon Mawa passage. We had quite a bit of power fluctuations that have been damaging quite a bit of equipment. So what initially started as a damage inventory of about $4 million from Typhoon Mawa has actually increased to about between $12 and $13 million to include our 3 chillers, 2 450-ton chillers and 1 265-ton chiller. We're very concerned about the impact that power fluctuations have had on our chillers, and this is part of our report, our damage assessment to FEMA. Next slide, please. We have ongoing CIPs and CIPs that are in the pipeline, and these are also included in our 5-year CIP plan that is attached to our 5-year strategic plan. So additional HVAC system upgrades. This, again, rooftop mechanical packages for both A and B wings are in progress. Projected construction completion date is August of 2023. Procurement of a 4th set of air handling units is coming up in the 3rd quarter of 23, and we anticipate that going through the 2nd quarter of 2024. Procurement of ED, ICU, HVAC upgrades. These are owner furnished contractor installed, so we're working on the installation of those components. Installation of contingency AC split units. When we were struggling on just one chiller and we were struggling to repair our chiller number 2, we started to put in split units in very critical areas, in clinical areas as a contingency. And we continue to do that because we just have to be ready in case we were to lose a chiller for a short period of time. We can't just survive on fans throughout the hospital. We have an ongoing liquid oxygen tank enclosure expansion and replacement of our large LOX tanks. That's projected for completion 1st quarter of calendar year 24. We have ongoing angiography and hemodynamic machine replacement in progress in 3rd quarter of 23, and we anticipate completing that in the 1st quarter of 2024. We have an ongoing procurement award that has been given for our medical vacuum system where basically our medical vacuum system, our quadruplex is failing. We're down to only 2 out of 4 pumps that are working. So we've procured an immediate, our immediate solution is to bring in 2 pumps just to keep this existing one going. and we've already procured the replacement quadruplex because we know that's going to come in maybe 3 to 6 months time frame. So the 2 pumps is coming this month, the end of this month, and we anticipate the second one in August, just to keep us going, just to make sure that we have hospital-wide medical vacuum for suctioning of the patients, things of that nature. Typhoon Mawa recovery phase is ongoing. As I mentioned, we have a very large damage inventory that we're actually presenting to FEMA today, which is going to be at least $12 million. They actually were the first ones to visit any of the Gulf Guam agencies. They came to GMHA first, and so I'm glad that they did, because we have a lot of ground to cover and repairs to make. The Z-Wing second floor demolition, we're planning for a resolicitation and award hopefully sometime this year, if not early next year. We still need to remove and replace boiler number 2 in calendar year 2024. We still have concerns about our main electrical distribution panel and sub-panels, and what our old faithful 1.6 megawatt emergency generator, which may turn out to be a hazard mitigation project under FEMA Typhoon Mawa. We're looking to replace our GMHA CCTV surveillance system and our access control system. The surveillance system is actually in progress, at least a portion of it, first and second floors this year, and we hope to expand that into next year. And then we have other FF&E purchases that we are very focused on in line with our 5-year CIP plan. This is our IT network and systems infrastructure upgrades, replacement of OR towers, anesthesia machines, and scopes. So we're very focused on our OR, and then various other medical equipment in the pediatrics and radiology area. Besides the angio for radiology, we're also looking probably at the need to replace one of our fluoroscopy systems. And so next we're going to be, to conclude our presentation, we're going to transition to Dr. Prinz, who's going to close up this presentation.
Chairman St. Augustine, Madam Speaker Terlahi, and Honorable Senators Hafaday and Buenas. My name is Dustin Prinz. I am the Associate Administrator of Clinical Services at GMH. The problem that all hospitals nationwide have faced is that they do 2 fundamentally different things. First, hospitals deliver services to patients when they are sick, and they are paid for that and only that, which is our ask for the $42.2 million for this operating capacity. But the other thing that hospitals do, which is essential for a community, which is not paid for, is that they are available when somebody needs them. That standby capacity, or I want to call it our community responsibility capacity, is critical for this community. But hospitals are not paid for that. My apologies if I sound redundant from all my fellow people here. Reimbursements from public and private payers, except for the Medicare reimbursement to critical access hospitals, of which we are not one, do not compensate for fixed costs associated with providing this community responsibility capacity, which is essential to run in rural communities like ours, where there are only a few hospitals that serves our rural community. The provision of community responsibility capacity for a remote and less populated rural community comes at the cost of financial viability for hospitals like ours. The cases that come through our hospital are generally patients who are more sick as a result of post-pandemic and post-typhoon, which is taxing us to a degree with our entire GMHA family in providing our services. Our custodial social cases, which is a direct part of our community responsibility capacity, is specific to our homeless population, our elderly who cannot go home because they are unable to take care of themselves, or their families cannot afford to take them home to their house because they work 2 jobs, and the sadness goes on and on and on for this. GMHA is a very caring organization, agency, that we are all in the business of caring for all patients for their acute care needs. But long-term social determinants of health is which we are not able. The monthly number definitely makes our operating expenses much higher. For example, we currently are even housing individuals who were affected by the typhoon in our B wing of the skilled nursing unit, of which 3 are still currently present. An example of our community responsibility capacity. What we are asking, the $42.2 million, will most likely not be well received, but this number includes pay adjustments, the pharmaceutical shortcomings with supply chain management nationwide, increased power costs, staffing costs that healthcare nationwide is facing, equipment costs, and maintaining an older building, just to give a few. This does not mean that we are not being good stewards of our island's money. This is just the authenticity of our situation in running a public hospital. There are so many rural hospitals that are closing in the United States mainland, as you could describe. We feel we cannot close because we are the only public hospital in Guam who provides services that other hospitals do not. And we take care of all patients who walk in our doors. This does not even exclude those from our neighboring islands who come for their care. The question we have to all ask ourselves are these social determinants, are they considered a core strategy or a distraction? The choice will shape how the healthcare system like ours is funded. We take very seriously in bringing those who we are leading to take them places where they feel joy in what they do. This is what keeps me awake at night when I look at our physicians and nurses and support staff. If they feel the joy in what they do, this organization will thrive. This is our challenge that we face. We will be an organization with greater quality and less cost. We are confident on this. But if we continue in this current situation, our quality will suffer. And the patients will suffer because of that. Our GMHA family will not feel joy, and this will have detrimental effects of which we are experiencing today. In conclusion, thank you for listening to all of us, number one. And we ask you as our leaders to help us as we lead our people. We are with you. We are here to support you, but we are asking for partnering in helping and supporting us. Servant leadership has to survive beyond us. We must inspire others to continue the same to help pave the path we have forged. We seek to serve our island, which is rooted in our people. For this I am humbled. Si Jesus Maase.
Thank you. Thank you to the panel for their presentation. I'd like to recognize also 2 other colleagues that have joined us, Senator Barnett and Senator Brown. I only have a few questions, and I'm going to ask the oversight, and then my vice chair will follow. How are you doing on a collection when it comes from DRT, when it comes to income tax? Collection for patients that are not paying? I'm just curious, what is the percentage? You getting everything?
We do get the garnishments, but as I mentioned, we're still cleaning up our aging, and so we've actually just recently discontinued the program because we want to make sure we're sending the correct information to DRT. But whenever there are garnishments, we are paid very promptly. But we want to make sure that we're sending the right information because we don't want to keep garnishing patients when their balances may not be accurate.
Okay, and how soon is that going to be wrapped up?
We want to finish that by the end of this fiscal year. So we did send the letter, I think it was just last month, to DRT to just put it on hold right now until we give them a new list that will be much cleaner for them to implement the program again.
Okay, is there any way then, other than holding it, is that you give a letter to the patient and say, this is what you take to revenue tax so they don't grab? And the reason why I'm asking that, because if you're looking at the end of the fiscal year, you're gonna miss the window when taxes are paid, okay? And you won't get to see a penny until next year. So I'm just concerned is that timing is the key, but I know there's a lot of...
Yeah, we end up doing a lot of refunds, and processing the refund, it takes so much time on the staff. When I was evaluating it, I said, we're just wasting too much time, and we need to send them the proper listing and make sure that we properly garnish. So once we garnish, it's just done, instead of
All
having
right.
to
Okay.
refund all the patients.
The next one is, because I heard you mention folks that come off island, that come to Guam and they get medical services. Is that from the COFA? Is that part of the Compact Impact, folks? And if they are, is there any...
And some from Saipan too,
Some of them are?
from Saipan, Sinamai.
Okay.
Yes.
Now, is there a mechanism in place other than to try to track them to pay? If they can't pay, that you can maybe reach out to their government and say, hey, you're getting federal funds, can you give us some of that money and pay for your patients? I mean, I'm just wondering, what is the mechanism to get reimbursed?
Well, they're also eligible for the Medicaid, and so
Okay.
we can assist them to apply for the Medicaid benefits.
Okay.
That's a recent thing.
Do you have is there an office from Public Health in GMH to help you speed up the process? I mean, there's got to be a shortcut to all of this, because everybody knows Medicaid, Medicare. Well, put somebody there so when somebody comes in and they check in, they say they qualify, boom, you're done, and you guys work out the system.
Thank you for that question, Senator. Yes, you're absolutely right. We do have eligibility specialists that are then part of public health, and also we recruited some individuals to be eligibility specialists. And so we're working with public health very closely, that once those applications are completed, public health then will process them.
Okay. And then you mentioned, my last question before I pass to the oversight, FEMA. You mentioned FEMA, and FEMA testified before the body. They're here to help harden the infrastructure. And if they're going to do that, what is that costing that we don't need to fund, that they're going to provide? Because I know that if you spend a penny, they'll reimburse you. I think if it's not at 90, it's at 100%. So I just want to make sure that the numbers are working this way, because if you got leaks, if they say it's FEMA covered, boom. If you show here $20 million in your budget, if you got the 20 million and you get reimbursed, then we kind of like break even here. I want to make sure that we're not going to try to figure out a way how to find you 42 when you don't need 42, because the governor was given an authorization of 50 million. And if she gets reimbursed and she helps you totally, that's federal money coming right back to the same pot that gave out. And there's no reason for us to sit here and say, we need to find you 42, and really maybe we only need to find you 10, or even less, or nothing at all but break even. And I just want you guys to think about it. If you don't have the complete answer for that, you can get it back to me, and I'll go ahead and pass off to our oversight chair, Speaker Terlaya, and followed by my vice chair, Senator Tidegre, and then I'll move along with the other senators.
Thank you,
Madam
Senator.
Speaker?
We'll chase that down.
Okay, thank you.
Thank you. Thank you all for your testimony today. Very much appreciated, and it's very thorough. Could we just go back to the collections issue real quick? So $100 million less than FY22 in billings. So I know Ms. Hechinovi said that this is because of the system shutdown plus the change to the new EHR system, that's causing like a delay in billings. Do you expect to recoup then this $100 million loss during this fiscal year, or you're just going to wash that and go forward and try to improve?
No. What we're doing, the priority in the billing department is, because we have 90 days to bill the on-island payers, those are prioritized. We have 1 year to bill Medicare and Medicaid. So because we have more time for those, we don't rush those as much as we do for the private insurance. So those are the ones that we're really pushing through and getting the claims out. And we're actually just behind on maybe the last 30 days or so. So our billings have been keeping up The problem with the implementation with the EHR is the bills, the charges are not all coming through, so we're concerned that we're not capturing all the charges that, just because of some interface issues here and there that we're seeing, but we definitely will bill everything that we can.
Is that strictly an issue for your billing department, or is that your consultant's issue, or who's handling that part? Where you're seeing billings not coming through, or?
It's our billing department. So in our patient affairs department, we have a new section we created for revenue integrity that keeps an eye on the charges. So when billers or they see something missing because based on the medical record, there was a procedure done and, for example, an x-ray is stated in the medical notes, but they don't see the charge dropped on the bill, then that's when they would go in and investigate why that charge was not dropped. And so there are periodic, there are times when, like radiology department, for example, will notice something is wrong with the interface and we need IT to come and look at it. So for a certain period of time, we may not have charges dropping. Of course, we're informed in billing, so they know to look out for those bills that may come across without charges for x-rays and what have you.
So you're relying on like the radiology department to notice it first, inform billing department, and then billing department calls IT?
Part of that, but sometimes we'll notice it just on our end alone that we're not noticing the charges are not dropping or batches are not coming across. So we're all keeping an eye every day on the movement, on the implementation of the EHR, because the charges are really our biggest concern.
So if the new HR system was implemented in October, we've already passed the 90-day period for a lot of the claims. Or a lot of the charges, right? And you're working on just the last 90 days worth, supposedly.
Well, even if there's a bill that comes through that may be missing charges or missing, we'll still bill it. We want to still get as much. If something is missing, a $25 charge or what, it's okay, we'll let it go, and we just want to get the bill in on time.
And so you intend to catch up on that 100 million?
Yes.
Okay. The Medicare, on your financial highlights, it shows that collections on Medicare is less than FY22 by a couple million, but the Medicaid is way up, so you're getting a good job in the reimbursements on the Medicaid.
Medicaid, yes.
And the third-party payers is also lower. You mentioned, you were going kind of fast on this part, and you mentioned there was a domino effect. Can you just explain this decrease in Medicare and third-party payers?
So generally in all, with the issues we've been having on the EHR and the charges, like what I just discussed, it is going to go down into less bills going out, less revenue being captured,
Okay.
less bills, and then of course less going to be collected.
All right, okay, so it's not an issue with the insurance companies being cooperative or reimbursing what they're being charged?
Not entirely. We still have some issues with the payer, yes.
All right, and you're able to take care of that?
Yes.
All right. The, you had a chart on appropriations, and then in the bottom you said appropriations not received, so 2.9 still pending for FY23,
Pending,
and
yes.
that's normal,
Yes.
right? Okay. And then there's a 1 million still pending for FY20, and 865 for FY21. Do you expect to get those?
No.
You don't? Why not?
Well, I believe it was because the pharmaceutical funds our portion of it is based on how much is collected for GRT. And so if we don't reach that threshold to cover our appropriation, then we just don't get whatever.
So you're saying the appropriation level was too high based on the pharmaceutical revenue that actually came in?
Yes, that seems to be it.
Okay, well, that's a perfect transition then to this, what your budget is, right? So you're asking for 19 million more than FY23, and that's 19 million more than the governor's request was pretty much status quo for GMH.
yes.
So that's 19 million more. 5 of that is from the general fund, but the rest looks like it's supposed to come from this pharmaceutical fund. And I overheard the OFB during our budget meeting say they don't expect to receive 33 million pharmaceutical fund for GMH, which is what you're basing your budget on. They are only thinking they might receive 20 million. it might be less than what you're listing here as an expectation. And if that happens, what happens to your overall budget?
That's a very good question. Yeah, we've thought about that. If we don't, we have our expenses already projected at the 193 million. And it's pretty much what's happening right now when we don't have enough to cover. We sacrifice other areas. So for example, when a certain equipment or something breaks down, or the parking lot roof was falling down, that's an immediate need that we have to fund right away. So we have to go back to the budget and unfund other things that we just can't possibly fund because this urgent issue has come up.
If you are able to obtain or recapture some of that 100 million in lost revenues, would that make up for that shortage in pharmaceutical funds?
I'm sure it would help, yes.
In other words, you haven't budgeted that in yet, right?
No, we made the projections just based on our current,
Collections.
actually our patient census and the trends with how many patients are coming in, how many are inpatient and outpatient, and even the demographic of whether they're in Medicare or a private payer, and then we base it on those historical trends.
All right. And you said there's a cap on the reimbursement of Medicare. Can you just explain that again?
Because of our TEFRA status, Medicare only...
Your what status?
TEFRA, that's the Tax and Equity Reconciliation Act, Fiscal Responsibility Act. We are under that type of a payment module, and so they cap us. So if you come into the hospital, and you're in the emergency room and in the ICU, and your daily bill is $5,000, we only get from Medicare $1,500 per day. That's all they will pay us.
All right. Is this the same thing as the reimbursement rates? Medicare's, like, approved Medicare reimbursement for GMH is lower than some other
Yes.
places, right?
Correct. It is.
So have you made any progress in, I know in past years they had done some reconciliation and were able to raise some of those reimbursement rates?
The rebates is what you're talking
Yes,
about,
yes.
ma'am? We received the rebates, the last time was 2016, 2017.
I haven't heard any in a while.
Yeah, right, and we have to apply for it.
We have
And
not.
the rebates is based on patient discharges per the Medicare cost report for the prior year. So when we submit our Medicare cost report, that's when they analyze it, whether or not there's going to be a settlement that we were underpaid or overpaid.
Yeah, but we do need to explore the rebasing again, and that is part of our strategic plan, is
Okay.
to seek the consultant to help us get the rebasing again, because it's already been 10 years, so they're paying us based on costs from 10 years ago, and of course,
Yes.
they're so high right now, so we
Yeah,
do need to explore
I
that.
thought that was done on an ongoing basis by
No.
GMH as part of its strategy.
No.
Okay, so you talked about outsourcing bad debt collections. Could you just explain that? I know there was a controversial contract not too long ago that's ended now. I know you've since hired 2 attorneys. Are they not doing the collections for you?
It's part of our cleanup of the debt of our aging accounts, and once we get a good number on what those self-pay patients are, we would think it would be more efficient just to hand them off to a collection agency and have them collect those very difficult, hard-to-collect accounts.
All right, so you've made no special requests for CIP projects. I think according to what you've submitted in your budget packet, there are CIP projects, and Mr. Kando explained, ongoing and projected for the upcoming years, but you plan to fund those all out of either your revenue or grants or just the regular operating budget, right?
Yes, ma'am.
And then this alternate care site, it's the first I've heard that this is like I know there's been an issue that we're incurring costs, but it's the first I've heard that GMH is going to be the one to lead building an alternate care site, and I see it's a FEMA PA grant. They are going to fund the 3.9 million?
During COVID and working with FEMA, we were able to submit a proposal, a grant proposal for the SNF, a skilled nursing facility, to be a alternate care site as a part of COVID-19. Of course, we've actually been using the skilled nursing facility for many, many years as an alternate care site for all hazards, all emergency responses, but this one was specific to COVID, and it went through it went through revisions, and it finally ended up on a non-acute care model. So the reimbursement that we're expecting, that FEMA is looking to reimburse us, is for costs incurred for various medical equipment that we had procured in support of the alternate care site.
SNF.
If
So,
I may.
and then, so
Madam
that other
Speaker.
one that you discussed about building a new alternate care site for 3.9 million, is that different? Or
No.
that's-
What happened, Madam Chair, Madam Speaker, if I may explain, when we initially submitted to FEMA that public assistance application for SNF to be converted to an alternate care site for COVID, it was tagged at $15 million. And we got approved by FEMA. Unfortunately, we couldn't move fast enough to bid for a contractor to do an RFP, bid for a contractor to then convert that. And so therefore, it went over a year. FEMA then informed us that because their mindset was it was supposed to be an immediate transformation of that skilled nursing facility to be an alternate care site, we did not act on it immediately because we were still dealing with COVID. We couldn't get a contractor. We didn't do an RFP. So therefore, we rescoped it, and then they dropped it down to 3.9 million.
Okay, thank you. In FY23 budget, there was a special line item for 5 million for specialty doctors. Was that utilized to help recruit specialty doctors?
We're still waiting for the audited, it was conditioned on the audited surplus number, and the audit hasn't come out yet, so we're still waiting for that.
So they haven't given it to you? And are there any areas that CMS has said need to be addressed that we should know about here?
A lot of the citations that CMS in their last visit were primarily the care that, because they came because of complaints. Some individuals made a complaint with regards to I think, admission and transfer. And I can't remember the details of all the citations, and I was on leave, so do you want to expand a little bit more on it, Dr. Prince?
So there was, thank you, Madam Chair. So there was some, there were some complaints that were about whether or not wounds were developed in the hospital setting. And because if it is in the hospital setting, CMS will not pay us for that. And it was deemed that that complaint was unsubstantiated. And there were also some other complaints based on food quality that was given to patients, and that was also unsubstantiated. In regards to other CMS findings, there were some on infection control. There were some on, in regards to nursing, and also with our medical staff compliance. And that is, and we have already given our corrective actions, and they were approved.
All right, thank you. In the FY23 budget, there was also a provision for 15 million from the audited surplus fund for hospital capital improvement funds, including the labor and delivery ward that was authorized in Public Law 3573 several years ago. We saw in an audit that money was never used from the original law. So I don't know, they put 15 million more last year we put in the budget for additional capital improvement projects. So you've not received that either. Have you used any of the money previously authorized for the labor and delivery ward?
We had DOI compact impact funds that were actually to fund the FF&E package of what that original family birthing center was going to be, and so that was about at least $3 million that we procured for the L&D, the OB ward, and nursery. A little on pediatrics, but mostly those three units on the second floor. And so, yeah, we expended those funds. We bought them new medical equipment that they needed for their critical infrastructure.
If I may add also to that, based on my recollection, the requirement for that was also to get upfront funding from a financial institution. And when we did the RFP or the bidding, we didn't get any. And so we could not proceed any further with it.
All right. Okay, so this appropriation is still pending. That 15 million from in the FY23 budget from FY22 unaudited, or
Correct, ma'am,
hopefully
because-
soon audited, right?
Right, it's depending
Okay.
on the audit.
Do you just two more questions. I know my colleagues are impatient, but the fees. So you've been increasing fees, and you outlined today especially that room and board increase, and that's been covered in the news. Do you find that, I know you based it on, you said a Medicaid report, 2019 or something, but you find that to be reasonable? You find that the insurance companies will not object and that the patients are going to be able to pay that?
We did have a public hearing a couple of weeks ago on the rates, and most of the insurance companies did attend. There was only written testimony that was submitted a few days later, and all of them had asked for reconsideration, which we expected. They don't want the rates to go up. But we feel that the rates are reasonable because they're based on FY19. We just wanted it to be fair. If we did base it on FY22, I mean, the rates would be unattainable, really. Nobody would be able to afford
Much
them.
higher.
Yeah, and we also did a comparison to the rates charged at GRMC and also to CHCC and Saipan to make sure that we were at least on par with their rates as well.
Okay, great, thank you. And you expect those to come to the legislature when you're done with your process?
Yes, we're waiting
All
for
right.
our board to approve it, and then the whole packet will be sent to the legislature.
All right, and then so my final question is just this, seeking this designation as, qualifying employer so we can attract additional medical staff, and the critical access hospital. Are you just beginning that, or how soon do you expect we can really fully apply for those designations? Just
Speaker.
beginning?
Right, we're just beginning that, but those are options that can help us, definitely.
All right, are you seriously going to pursue those?
What was that?
Are you going to seriously pursue those, or
Absolutely.
we're thinking like in the future?
I'm
Right now?
seriously pursuing it as long as I'm in this position.
Okay, all right, thank you again, Sizus Masi. And thank you for all your work, of course, and congratulations again to all of those who retired this year, many of them serving over 30 years, one serving over 40 years in the hospital. Sizus Masi to all of your staff.
Thank you, Madam Speaker, and Oversight Chair of the hospital. I do have some questions with regards to the Department of Corrections. You collect $3.3 million is what you estimated to project, actually collect in FY24? Is that a project? Okay. But what is the reality on the service that you provide them? Is it exceeded that amount of 3.3?
How we charge the Department of Corrections, so we have all of their expenses are charged to a GL account, including all their personnel costs, all of the supplies and equipment or stuff that we buy for them, and we turn around and bill that to them. So whatever costs we incur for DOC is turned around and billed to them. So it is 100% paid back to us.
Right, and in FY22, how much billing did you bill them, and how much did you get from DOC?
If I can also interject, it's not just the operation of the on-site clinics, but when inmates come into the hospital as inpatient, those we bill also. We can
Yep.
send them the invoices.
Exactly.
Thank you.
Yep, so I'm just trying to see where the gap is here, because I'm hearing that GMH does not receive the full amount whenever they have, send the billing over to DOC, that sometimes you don't get those paid. So is that true to form?
That was prior to 2019. There was a problem getting the payment, but currently we do. We receive it every
Okay.
month, yes.
So in FY '22, not a problem?
Not a problem.
Okay, and then it's anticipated about 3.3 million?
Yes.
Okay, the other question I have is regarding the ARP funding. Anticipated, you have about 1.5 million left in the ARP funding. I might have missed it, but do you have any plans of utilizing that funding? It has to be expended by the end of December of FY '24 or the year '24. So you have about 1.5 million.
Is that from the slides, ma'am?
Actually, from the ARP funding that the legislature receives coming from the governor's office, they give us a report to show us how much has been expended. And I'm showing that there is still $1.5 million that you guys have. It's been given to you. Are you you're not aware of that, huh? Oh, well. Allow me to
Get it?
allow me to send you the report if you haven't received it. But yeah, there's 1.5 million in there.
Yes, please.
Okay, thank you. You can actually ask BBMR because they're the one that provides us that report. So I'm sure you can use that money right away. You said that you're having issues with the increase of the 22% pay increase. You mentioned earlier that it's hard to meet your goals because of this increase. Can you kind of explain?
I'm sorry, can you repeat that?
Earlier you mentioned something about difficulty, making,
Recruiting?
yeah, the not recruiting, but the 22% pay increase that was given to the hospital, and that you are having difficulty in, reaching your goals in paying out because of this. You mentioned that earlier. Oh, maybe I might be mistaken because now the aircon sound has been gone. It's hard to hear, so now we're clearly hearing much better. But are you having any issues paying out the 22% pay increase?
We're paying it. We are paying it, and we're also receiving about $300,000 every pay period from DOA to
pay
the GPP. Yes.
Okay, well then you're a lot better off than DOE, that's for sure. Okay, the other question I have is, do you have any, well, that's kind of ridiculous, but I will have to ask, do you have any lapses anticipated?
No, ma'am.
No, I didn't think so. Have you had lapses in FY '22?
No, ma'am.
Okay. Overtime, I'm noticing your overtime. What are you doing to try to, overtime is so much more expensive than regular salary, so what are you doing to offset that?
We are enforcing the policy in terms of those who are exempt. They're are not eligible, but they need to then submit prior authorization because, the hospital is old. And, we do have people that have to stay back, FM especially. Even the manager himself responds to the calls that we need to get this thing done, we need to get this fixed. When I went up to ER and it's pretty warm, I called him that we need to get split units installed into the emergency room, and that was like a Friday afternoon. And so, those are circumstances that are not predictable, but they respond. And so we are enforcing the compensation policy that we have in place.
Okay, keeping an eye on that one, it's important. On the unclassified positions that you have, here it says 49 positions. Are any of those unclassified positions vacant right now?
I don't have the listing in front of me of what you have. Is that the staffing pattern?
Yes, yes, it
in our
is.
budget? Okay. If you give me a minute to take a look at it.
Okay, well, I'll have one of your staff look at that, and I'll continue on so we don't delay this any longer. Now, one of the biggest concerns I have, and I've always had a passion for, looking at ways to protect our, when it comes to cybersecurity. And of course, we had an issue at the hospital, not only the hospital, but it happened at GCC, it happened at University of Guam. And it's not going to stop. You're going to see more people hacking. I mean, we had a bank issue recently, of a hacking there. So I did attend the meeting with a couple of my colleagues regarding what really happened during that time. I'm also aware that IT, the government of Guam has sent over somebody from IT to kind of help the hospital because, this is a huge, huge problem. And I don't know how much funding you're putting into upgrading, but you have here other FF and E purchases. This is on the capital improvement projects that you have here. And I kind of wish you had put the prices of, or how much the estimated cost for all these ongoing CIP in the pipeline, how much it's going to cost. It'd be very helpful if you can provide that to us, the cost of these projects.
We've actually captured those costs in our 5-year CIP plan, which is attached to our new strategic plan. All the useful life, the age of the existing, the actual estimated cost for all of those. So those that have been completed, those are also showing some of those in the calendar year 2023.
Speak into the mic again, I'm sorry, I can't yeah. So the one that you have here, the ongoing CIP and in the pipeline, you have a total cost of all this?
We can make sure that we can give you an accurate figure on that. We have those actual costs.
I think it's very important, so we can see how far you are and what's really needed that's important, and especially when it comes down to the infrastructure, the IT network system infrastructure upgrade in particular. What is the cost for this particular section?
Senator, if you can look at page 23 of the PowerPoint slides, it does show there in terms of the hospital information and communications technology infrastructure upgrade for fiscal year 2024, we're looking at 16.2 million.
Yep, I have that page 23, but no, I don't have
Slide 23, this is the one.
No, I don't have that. Do I?
Fiscal year 2024 equipment and CIP funding requirements.
She said 23. 23, all I have is this right
Sorry,
here.
it's 21.
Oh, 21.
My
okay,
eyes
thank
are...
you. No worries, no worries.
My apologies.
Okay, so we're looking at the communications technology infrastructure upgrade. Is that the one that you're talking about? Okay, and you're looking at this project alone at 16,200,000? Oh, after you're completed, it'll be 79.5, yeah, because you're looking at what it's going to cost. Well, in FY23, did you have the 16.6 million in FY23 to cover this? No? Okay, well, that's scratched out. And then now the 16.2 million, where's that money? Where's that coming from? You got any federal grants down the pipeline or FEMA money or?
We're searching for federal grants opportunity, yes,
okay,
ma'am.
well, this, I can't stress what happened to the hospital when you had a breach. This is not just, the power going down. This is important, technology that helps doctors determine what blood type a particular, patient has or what the medication that's needed. And, technology has helped speed up this process. And for you to just say, okay, we didn't have any money in FY23, now, and that's when we had this problem, and then you are not even, having a plan for something like this, it's very discouraging. It's scary for anybody to go up to Guam Memorial Hospital knowing that it already had a breach in cybersecurity.
If I may correct, it wasn't a breach. Based on the code of federal regulations, we did not, upon the investigation of that IT, it was not, there was no reasonable evidence that there was a breach in terms of acquisition, access of
Hacking.
personnel, protected health information, so there wasn't. But there was, you're absolutely right.
Absolutely, there
we
was
are
a
vulnerable,
breach.
and so
There
therefore,
was, for you to say there was not a breach is outright not true. There was a breach, regardless. It was somebody in your
there was
employment.
an unauthorized access.
Yeah, in your employment. That's a breach. Regardless if it comes from somebody in another country, it's still a breach. You know, Lillian, I can't stress how important this is. If you looked at, anybody can go online and look at other hospitals that have been hijacked by cybersecurity and held hostage, paying in millions of dollars to release them. This is a huge issue.
Mm-hmm.
Cybersecurity is one of the.
that.
I'm very happy to hear that IT, you know, is actually helping you guys. This might cover some of the costs. You might want to look at tagging on with IT at the government of Guam. I mean, they have the equipment, they have the security all in place right now. There's, you know, because you're not an online agency, I do not know why IT is not helping people like Guam Memorial Hospital or other areas like the University of Guam or GCC that's already been hacked.
Senator, the Office of Technology, led by Frank Lujan, are directly assisting us. We've been working with them since that shutdown and restoration. Mm-hmm. And they've been working, he's been working to actually pull equipment, IT equipment from other GovGuam agencies in the way of switches and servers that have made a huge difference to that restoration effort. And again, I reiterate, firewall. That's why we were able to bring in new firewalls. So that help has been tremendous. And I reiterate, based on the investigation, our lawyers were involved. The CISA, the Cybersecurity and Infrastructure Security Agency, was involved in assessing what transpired. And I reiterate what Lillian stated: there was no breach.
There was a breach. But do you have an MOU in place with the IT department, with the hospital and the OT? Do you have an MOU in place?
We requested by memo an official request for the governor to allow Frank to be with us and help us out. And so he's been coming regularly. He's been on site.
In an MOU or?
It's not an MOU, it's a memorandum that we
Okay.
requested and was officially approved by the governor.
Okay. The other question I have, and then we'll go to the employees on the unclassified, but does the Guam Memorial Hospital Board approve your budget before you come and present it to us? Are they involved?
Absolutely, yes.
Okay.
They are involved, they are engaged in this
Okay.
process.
And then the last question I had was the 49 unclassified positions. Are any of those unclassified positions vacant currently?
The question is the 49 positions that are vacant?
Yeah, that I have, the sheet that's prepared for by our Office of OFB, it's showing here unclassified was 49 in FY23, and then going into FY24, it's also requested 49. So my question is, are any of these unclassified positions are vacant right now?
I have to look into it,
Okay.
Senator. I don't have
Yeah.
the data right now, but I will
Appreciate
certainly
that.
look into it. Thank you.
Yeah, and then let the, our chair, notify our chair on that, and as well as myself.
Yes, ma'am.
As
I
the
will.
vice chair, I'd appreciate to find out that
All right,
information.
thank you.
Okay, and to all the employees at the Guam Memorial Hospital, and what you've been through with the typhoon, COVID, and everything else under the sky. I'd like to thank you for all your dedication and hard work. And I hope that, Lillian, you continue to keep us in the loop with regards to any progress on the meetings for a new hospital, the building of a new hospital. I haven't heard anything about any meetings updated. We passed legislation to have this, and
We haven't had any meetings. at least that
I don't know why
I
not.
haven't.
I really don't know why not. We worked very hard to try and be a part of this, the building of a new hospital, which is desperately, desperately needed. Right. We also need to look at what kind of funding we have to prepare our current hospital, because I was told during the typhoon, and looking at your, told during the typhoon that it was raining in the hospital, flooding in many of the areas, and that when I looked at your report here on what has been completed, capital improvement, recently completed projects, I'm seeing roof repair, coating, roof coating, structural architectural package completed for D-wing, A-wing, D-wing, D and E. These were all completed. But yet, the hospital was still flooded during the typhoon.
That's right, Senator. So it's the roof and envelope that we need to upgrade. We've worked on the roof. The roof for A, B, D, and E wings were not leaking. They did their job during that typhoon.
So where did it leak?
They were leaking in areas where we were having drainage issues. Even on in the vicinity of the Z wing, which we're trying to demolish on the second floor, there are certain drains that were covered during the typhoon by debris, like solar panels that had been knocked off of our roof. They were covering the drains, and that's what was leaking into our main corridor, and then down the one of our main corridors past the dietary, like a river. And so we couldn't actually go out there during the typhoon and actually remove the debris because the winds were so strong.
Okay, well, I greatly appreciate you really paying attention to that particular situation, because we are anticipating to have, of course, according to FEMA, additional typhoons. We're in typhoon season. It just started. We're starting to have it. So whatever you're going to do right now, I think it needs to be done now to prepare in case another typhoon comes, because we don't want to see people, you know, in the middle of the hospital being rained on during a typhoon. So please look into that. And thank you, Mr. Chair, for the opportunity.
Thank you, Senator Tyree. Senator Lujan, sir, and you'll be followed by Senator Fisher.
Thank you very much, Mr. Chair. Good morning, panel. Thank you very much for being here this morning, and thank you very much for all that you do and staff at, of course, GMH for everything that you do. If I didn't say that, Dr. Princess will be on me. But thank you very much for that. Just a couple questions here in regards to the ER admissions here. In the first 7 months of the fiscal year, from October 2022 to May 2023, you've had 12,065 patients that were seen, and of that, 26% or 3,183 were admitted, right? Okay, and that's just the first 7 months. So it's safe to assume that by the end of the fiscal year, those numbers will double, right? Okay, at 26%. Of the 12,065 at this point, what are the percentage of patients that are seen that come in uninsured, that have no form of insurance at all? Roughly.
I'm going to yield to you.
It's about 15 to 20%.
15 to 20%.
Yeah.
Okay. Is that reflective on the admissions as well from ER at 26%, or the 3,000 at about 15 around?
Yeah. It's been pretty consistent throughout
Okay.
the years
Okay.
in our payer mix of how many are
Okay.
actually self-pay.
Okay. And that's a combination of COFA, just local folks not insured,
Yeah,
or folks coming
across the board.
Okay. And you were saying earlier too that you're seeing a lot of sicker patients coming in. So a lot of folks who again are not insured use the ER as their primary care facility. Yeah. Yeah. Yeah.
May I add on to that?
Yes, sure.
Yeah, so honestly, post-typhoon and actually post-pandemic, patients were delaying care.
Delaying care.
Delaying care in their primary care. So this was huge for all of us. I mean, I see Dr. Lozama back there, and he's one of our hospitalists and a great one at that. And honestly, it is becoming more and more complex of chronic more chronic cases that have more acute problems than ever has been seen before. Also, younger patients becoming more chronic. And that is taxing the financial system of the government, federal and local in itself.
Sure, okay. And again, it's just first 7 months, and this number will double, of course, for sure, with that. And the reason why I ask this, because I know there's been conversation, I know that the government of Guam is looking at self-insuring. How do you folks feel about that? I mean, because I've been looking at these numbers and I'm asking you the numbers in regards to uninsured patients and, of course, the capture rate, right, in regards to collections. And I'm just not confident in Gov Guam self-insuring and whether they will have a bigger capture rate aside from, again, the non-payers, and whether or not the Gov Guam self-insuring will have even a bigger capture rate. And I think these numbers will probably even be higher.
Well, to address the self-pay issue, we really try to get them signed up for Medicaid. A lot of them don't know how to do it, or they don't even understand it's there. So just giving them the form, our social workers even help them get all the documentation together, so at least they can get something as opposed to no coverage at all.
Okay, okay. But how do you feel about, again, the conversation that Gov Guam is moving towards self-insuring?
I think that's just mainly for the employees in Gov Guam.
Yeah, but still, I mean, Gov Guam self-insuring? Which pot? Which pot is it going to come from? And that's what I'm saying, because these numbers are going to rise. I'm just saying the capture rate. I mean, if Gov Guam is going to self-insure, I don't think the doctors are going to be very happy about that. No comment, Dr. Prince.
You know, honestly, Senator Lujan, healthcare economics is complicated.
Yeah.
I'll just say it as that. You know, there's now new master's degrees in healthcare economics all across the nation. And why? Because it's complicated. Yuka can actually attest to this. It's not like in the outside sector, like Port Authority, for example. Guam Memorial Hospital, GRMC, name the hospital, it is complicated. It is complex. But what we cannot do is skirt taking care of our patients to the best of our abilities and supporting our providers and our nurses, our physicians, our support staff, our housekeeping, our FM. Everybody has to be supported. And that is where the issues come in.
Yeah, and that's where I'm coming from as well. I mean, it's great if we had this Gov Guam big pot, you know, this rainbow continues to shine in this big pot, and yeah, that's fantastic. But that's what I'm worried about. We move towards that, although it may be just for Gov Guam employees, that, yeah, I don't think it's going to be, you know, those problems are just going to be exacerbated even more, and we probably don't need a master's degree on medical care economics to be able to know that, Anyway, one last question, actually. Read about net payroll. Where are we at with that? I mean, is the hospital making full payroll, gross payroll with that? And,
Yes, we are.
Okay, so we're not behind with anybody and all that? Okay. So anyone that needs to retire can retire on time and all that?
Yes,
and that, okay.
they should.
Okay, great. Anyway, thank you very much, Mrs. Chair. Yeah, and like I said, I'm very concerned about Gov Guam self-insurance. And so we'll be keeping an eye on that. And yeah, definitely. Thank you very much.
Thank you, Senator. Senator Fisher, do you have any questions or comments for the panel?
I do. Thank you very much, and good morning. This is gonna be kind of slap shot, but I understand that visiting hours are suspended at the hospital. Is that true?
We just lifted the suspension as of Monday.
I'm
We
sorry.
lifted the suspension. We're back to normal visitation.
Oh, good.
You know, It was just in effect Monday.
Excellent. I assume that you imposed the restriction because of the typhoon and,
Well, that and COVID primarily,
COVID?
to protect the patients, the public, and the staff.
okay. So I'm sure many people are going to be happy to hear that. So
Sure.
yeah, so thank you for that. You had mentioned earlier about the debt collection. I noticed that in this fiscal year, you're on track at about 53% collection. And you want to outsource your debt collection, is that correct?
Eventually, when we have and there's so many accounts, and that's probably the problem, is we only have 3 people in collections right now. If we have very difficult, hard to collect that are really old, we think it would be just more efficient to outsource that and give it to a collection agency. We pay them a fee to collect those instead of having to hire more people to get on the phone and call all these people.
Okay, I know that you had, I know there was some sort of a contractual hiccup earlier in the year involving debt collection. Could you explain that? There was a provider that was...
So the contractor was actually not doing collections. We still were. They were consulting us on improving revenue cycle management in the hospital.
On improving what?
The revenue cycle
Okay.
management, the whole billing, collection, coding, all of those processes.
What was the name of that company?
MedHealth?
MedHealth? Are they still doing that?
No.
Why was the contract either terminated or suspended or?
The contract was for 1 year, and they provided a variety of consulting services to us. A little after they started, we actually hired somebody with extensive revenue cycle management experience who worked alongside of them, and now she's actually in charge of revenue cycle. And then we just got to the point where we felt we could continue the work, and so we ended the contract.
Okay, and from your statement, do I understand that MedHealth, the organization, did not have the requisite expertise to provide the revenue?
They did. They had the requisite expertise, but they did help us a lot with implementing our new bill scrubber. We needed some consulting services for that when we had the back and forth with the vendor. They helped us set up our revenue integrity department, and so we were able to set up a separate section within the billing to monitor charges, which we didn't have before. They helped us understand some of the issues we were having with our Medicare billing. So it just got to the point where we felt like they've done enough and we want to take it over. The contract was never meant to be in perpetuity. It really did have an end date, and so when we felt we were at that point where we could cut it off, we did.
Okay. Do you know who the principal officers are or were in MedHealth?
We know Mr. Glenn Hermes was the CEO.
Hermes.
Mr. Glenn Hermes or Hermie. He was the CEO that we were communicating with.
Glenn Herman?
Hermes, Hermes, I believe is his last name.
Okay, do you recall the names or identities of any of the other officers at MedHealth?
No, we didn't meet the officers, we only met him. Who we met were the staff, the consultants that were.
There is, I think Mr. Rene Ramos.
Rene Ramos?
And there's one more, I just don't remember the name right now.
Okay. The first gentleman you named, Hermes?
Glenn.
Glenn. Was he on island?
He came on island a couple of times and we met with him in person.
Okay. So,
Yes.
Was MedHealth an off-island company or is it a Guam?
That's our understanding, was that they were from off-island. They were based off-island.
Okay. And I know that you said that you had spoken to him at least a couple times. I suppose he was a signatory on the contract. Were you dealing with anyone else on island about that?
Not really. Mr. Rene Ramos came to the first meeting that we had, but after that, I don't think we had any other meetings with them. It's been primarily Mr. Glenn Hermes.
Understood. When you came into this contract, was that pursuant to a request for proposal?
We completed the RFP, yes.
And did the RFP arise sui generis? The RFP, the idea for it, the idea for the contract, what was its origin? Was it the hospital, or did Rene Ramos or Mr. Hermes, did they propose that to you?
I guess they knew that they knew that we were challenged with our collections.
Okay.
And so, yes, they initially mentioned that, you know, they can, but I said we need to go through the RFP.
I'm sorry?
We need to go through the RFP procurement process, was what I had said. We just have to go through that process, and we did. We submitted everything to the AG's office.
Okay, thank you, I'm sorry to interrupt. How many proposers participated in the RFP?
Only one submitted.
Only one?
Only
Was
one
it-
proposal.
Was that MedHealth?
Correct.
Yeah.
Oh, no, we had two.
Oh, okay.
We had two.
Who was the second? You can answer that.
I can't even remember the name.
Okay, yeah, okay.
It was a local company.
And a fundamental question, how much was the contract worth?
We paid them 12% of collections every month over 7.2 million.
Okay, the first 7.2 went to the hospital. Thereafter, the 12 cents out of every dollar went with
Yes,
MedHealth?
yes,
Okay.
correct.
And did you require MedHealth, well, I'm sure you did, require them to report to you how much they were collecting over and above the 7.2?
Yes, we tracked that.
Having tracked that, do you recall how much did MedHealth actually make on the contract?
About $4 million.
$4 million? And the contract was not quite for a year.
It was a year and a half almost.
Oh, a year and a half, okay.
A year and 5 months, I think.
Do you think that,
Year
did
and
you
a
get a fair return on your investment?
We did have increased collections at that time. They really helped push a lot of the Medicare. We had so many issues with Medicare, so that was
Okay.
where they really helped us a lot with the Medicare claims.
Okay, thank you. I want to move on. Medicare, Centers for Medicare, Medicaid, CMS, right? Are they the ones who are the authority or the entity that can grant rebasing?
The question, if I may repeat, are they the ones in authority to grant
Yeah,
the settlement?
Yeah, I don't
We
know
work with the
I don't know what
consultant.
I don't know what the verb is. Award it or give it to you, the rebasing?
They're the ones who award us the settlement,
Okay.
the rebasing settlement. It's Medicare.
Okay.
CMS.
CMS.
All right. If they're rebasing, there must be a base. So what is the base right now?
It's based on FY 2014 costs.
Okay. And do you know, is it fair to think of it as how much you get per bed per day?
Yes,
Okay.
per day. Per
So the amount of money that you will get from Medicare, Medicaid per bed per day is based on 2014 figures?
Yes, but it is adjusted. There's a market basket index, like CPI, adjusted every month. It's about 1 to 1.5%. It will go up every year.
Okay.
It's not much.
So how much does a hospital get per day per bed from Medicare, Medicaid, occupied bed?
That exact number, I would have to get back to you because it just depends on the census on that day. It changes every day. Sometimes we have a different mix of patients in the hospital. They're all self-pay, Medicaid, Medicare, private insurance.
Okay. But the idea behind rebasing is you will get more money from Medicaid, Medicare per bed or per patient?
Yes.
Okay.
Yes.
And it was based, and I understand it fluctuates, and you want it to fluctuate at a higher level, I suppose. Is that correct?
Yes, based on more current costs.
Okay, what's taking so long to rebase?
We do need to get a consultant because this is something that needs to go through CMS.
Okay.
And it was done earlier, and that's exactly how they did it, and it was successful. We'd like to follow the same path because we want to get the same outcome that what happened about 8 years ago when it was successfully rebased.
Well, this sounds like a, one of those things you're going to want a DC firm to do. Why don't you put out an RFP in the Washington Post or something? I'm sure there are a lot of sharks in the water for this, right?
We've just started discussing what are we going to do going forward on that. But the rebasing is definitely something we need to do. The mechanism and the way we're going to do it, we haven't fully discussed that yet.
Okay. Your hospital, compared to other hospitals of similar size around the nation, how are you guys doing on revenue and expenditure? Are you similar to other hospitals of the same size?
I am not too sure. I've never really compared us to other hospitals because we're just a very different, we're a very different hospital. We're in the middle of the Pacific Ocean, and we have a different demographic, different types of patients that present to us, so it's hard to compare. But in what I have learned happening in other hospitals is the costs have been extraordinary, and they have the same, staffing is another issue. The really big healthcare systems, I've heard, because they're a lot bigger, they're spending $500 million a year on travel nurses. And here we are thinking we spent a lot, but because they're so much bigger, of course, their scale is a lot larger, but they are really experiencing the same issues that we are as far as staffing and expenses are concerned.
Okay, the reason I was hoping to drill down more on the money side, revenue and outlays and so forth, because I was wondering if there are any outside management teams like Humana or Blue Cross Blue Shield or St. Mary's that have expressed or would be interested in taking over the management of the Guam Memorial Hospital Authority.
We haven't asked, so.
Yeah, I'm not sure they would, based on, if you guys are $42 or $42 million in the hole, I don't know that anybody would. But I don't know, you might want to, I know you guys are the experts, so you might want to think about whether or not that's practical. Okay, continuing my jumping around here. Ms. Posada, do you have an opinion on where the new hospital should be constructed?
Can you repeat that question? I'm sorry, I was busy writing notes.
Yes, ma'am. I'm sure you're aware, well, of course you're aware of the controversy surrounding the potentiality of a new hospital. Do you have an opinion on where it should be located for the welfare of the community?
Sure, for the island, for the welfare of the island. Central location is what my opinion is, what my preference is. It's easier access if we want to make, Medicare hospital services more accessible and available. A central part of the island is where I prefer.
Okay, so you're not necessarily, it's the whole Eagles Field, I'm sure you're very familiar with that, the idea of putting it in Manilao and so forth. So it sounds like you're not necessarily married to the idea that it must be at Eagles Field in Manilao.
I like Eagles Field, I like that, but if we've lost the opportunity, so therefore I still would like to see it located centrally.
Would it be practical to put it in this? Would it be practical to put it in the same location where you are today?
No, absolutely not.
Okay.
There's just no space. We cannot even expand. There's problem with parking right now, and to build a hospital where we are right now, it's a disruption to the services. Really pure disruption.
Yeah.
I know we're going to get complaints from patients that it's just not at all, feasible. It's going to be too noisy. People are not going to be able to park. Now that we've opened up the visitation, families are going to complain they can't find parking. And so it is not at all practical, nor is it reasonable.
Okay. Well, that's...
Thank you, though, for the question.
Yeah, you're very welcome. Okay, looks like, as you just observed, Eagles Field is off the table. Have you been thinking about any other locations?
Well, for my preference, It really should be near University of Guam, so that we can make it affiliated, and hopefully in the future it can become a teaching hospital.
Yeah.
You know, that will help bring in some medical students, nursing students, and other allied health professionals. So research is another thing that I think we need to pursue. But you know, looking far ahead, but definitely.
Well, I think that's visionary. I agree with you. A teaching hospital would be wonderful for the entire area. Does the University of Guam, do they have space?
Just from what I'm looking, there is space. There's an undeveloped area. The Dean Circle, and I know that those buildings there, I think I've had some issues with either asbestos. Quite a bit of those structures have been already demolished.
Okay.
The College of Agriculture has a really big area, you know, that very big parking space.
Okay.
So I think they do have, you know, land,
Sufficient space up there?
sufficient space. That's, I'm
Well,
not
that's-
an engineer and I'm not a,
Well, no, that sounds terrific. The infrastructure's already up there, the water, the sewage, everything else. I don't know either, but that seems like a very good observation to me. Maybe you could share that with the boss, you know, see what she thinks.
I will.
What, am I done? Okay, I'm going to hurry it up. Do you have any outstanding settlements in, litigation that is coming up? In other words, like you report to Deloitte and Touche. Do you anticipate large settlements?
It's the E&Y is who we're doing our finance audit, and so we're still going through that process. The E&Y is the one that is doing our audit for
Okay.
fiscal year 2022 finance.
Okay,
And
but
so
you don't see anything big on the horizon right now?
we still have some listing of some litigations.
Nothing that was, we have a reserve on our financial statements of about $500,000 for any
Okay.
large contingencies, and according to the auditors, it looks like that's going to be sufficient to cover anything coming up in the future.
Okay. And then I wanted to ask you, I'm referring to page 6 of the handout, I guess it was your slides. It's entitled Fiscal Year 2024 GMHA Budget Request. Contractual total is $41,482,000. When you say contractual expenses, what do you mean by that?
We put our physicians that we contract, they're in there. That's a
Okay.
big part of it. The travel nurses are in there, and then any other contractual services we have for like the copier machines, things like that.
Is the contractual expenses for this fiscal year 24, are they higher than they were for fiscal year 23?
Yes.
How much?
I think it was 4
$4
million.
Would, if we don't need the travel nurses anymore, shouldn't that contractual amount be declining?
We still have the travel nurses. We still anticipate we have had the goal of getting the travel nurses off of our expenses since, I think, 2021 or so. It's been on our to-do list, but it's really been impossible to do it when we have nurses leaving. The turnover is just, and we try to do as much as we can to keep them, increase their pay, offer them signing bonuses, all these things, but they still find reasons to leave. Yeah, there's a lot of competition for them, and so we will still need the travel nurses in order to take care of the many patients that we have.
Is there any way, I'm going to betray my ignorance here, but is there any way to encourage H1 workers to come in?
We are looking into that too. In fact, we just started a task force to see how we can then recruit from the foreign countries, primarily Philippines, because we have recruited, we have worked with them, and we've recruited nurses from that country.
I think is it an H1? I think so, right? The visa?
H-1B, or we can just go ahead and go with the visa.
Okay.
So, but it's H-1B.
Is anybody doing that work? Is the Attorney General's office doing that work for you?
No, we're doing it in-house.
Do you feel like you have the requisite expertise in-house to push it forward?
We do, but we're also looking for an immigration counsel, someone who is, an expert in immigration.
Okay.
Yes.
Okay. All right. And then I also noticed that for fiscal year miscellaneous, $664,000. What is miscellaneous?
Miscellaneous is like our, if I'm not mistaken, it is like our fees that we pay for certain things. I think for training, I can get you the specifics later, I can be more precise, but it really is kind of whatever doesn't fit in the other categories, but mostly I think it was for fees.
Okay. But you are tracking those expenditures, I assume.
I'm sorry?
You're tracking those expenditures, I assume.
Oh, yes, absolutely.
Okay. Continue, or just staying on page 6, I noticed that for the fiscal year 24, your fringe benefits are broken out separately for medical and dental and overtime. Fringe benefits of $20 million. What are fringe benefits?
Retirement.
Okay, so that's all retirement?
Yes, mostly retirement, yep.
Okay, is there anything other than retirement?
The Medicare tax we have to pay for the employees. I think the retirement insurance for the employees.
Okay.
And life insurance for the employees as well.
Okay, and page 11, please. You've got, and I'm looking at the category miscellaneous. If I compare the actual miscellaneous for fiscal year 22, I get 23 million, but now it's dropped to 700,000. What's that about?
Yeah, so in 2021 and 2022, we actually lumped all of our expenses for COVID related that we were going to use against all the grant money that we got into miscellaneous, so we could track it. And so that's why it's lumped into here for 2021 and 2022.
Okay, so that money is drying up.
Yeah, these are the expenses from those years. So yes, we've already spent the COVID money that we have received.
Okay. So for fiscal year 25, it'll probably look a little grimmer because the federal money is gone?
Absolutely, yes. And we've all been talking about it, that there will be no more federal assistance for COVID because the pandemic was winding down. Now it's officially over.
So no more money? No more money from Uncle Sam?
Not for COVID, anyway.
Anyway,
Yeah.
okay.
Although
Right.
the expenses are still there, it did not go back to pre-pandemic. Did not.
Grant. Okay, and now I'm going to go on to page 13, and I'm going to wrap it up because Senator, I didn't wrap it up yet. I said we're going to page 13. Yeah, I'm getting some serious stink eye from this guy. Gross revenues, that first line, I've just did, this is back of the envelope stuff, but as of today, or May 31st, gross revenues were $156.5 million, and that's 8 months, so that's $19.5 million per month, which means that gross revenues, just as a projection, using your collection so far, are on track for about $234 million. How did I get at that number? Because I divided 156 by 8. There's 8 months have elapsed. That comes to 19.5 million per month. 12 months in the year, 19.5 times 12 is 234 million. Again, that's just back of the envelope, but do you have a comment on that? Because your projected revenues are significantly less
Lower,
than
yes.
234.
So our gross revenues is really all the charges. So it's a good way to measure like volume within the hospital, how we're charging. But when we actually recognize the revenue, it's never the gross. So for example, as I talked about Medicaid and Medicare earlier, we only get $1,500 a day. So even if all these gross charges go out, we do not realize 100% of this. So we have to net it down to what we call the net patient revenue after we adjust it for contractual allowances
Okay.
and for bad debt that will not be collected.
Okay, but
Which
so
is
far,
76.
okay, I'm completely at sea right now. So far, you have collected 156 million.
No, that's
No?
gross revenues that we have, that's on the books. So when a patient comes in and they get an x-ray, they get a medication, all these charges start to drop on their bill. That's the gross bill.
The gross, okay, now I
Yeah.
get it. And the net is actually the dollars that came in the door.
Is what we expect to collect, yes.
Okay. All right, so I don't, thank you, Senator San Augustine, I appreciate it, and thank you all for answering my questions. Thank you.
Thank you, Senator Fisher. Senator Canasta, do you have any questions or comments for the panel? And you'll be followed by Senator Duenas.
Hopefully, good afternoon, or still good morning, panel. We've certainly heard a lot of conversation. So I don't really have much questions. I think they've all been asked already. So I wanted to thank you guys for all your continued service, your hard work, and wish you all the best throughout all these challenges. And our office remains open to supporting you in whatever way possible. And you have my support. Thank you.
Senator Chris, sir.
Jesus Masi, Mr. Chairman, I didn't want to just impose and take the opportunity. But thank you to the panel for being here and all the work that you and the team at GMH are doing and have done. Dr. Prince, I think you encapsulated the passion of what all of us believe, which is the service to our people at this level of care at GMH is absolutely paramount. And I think all of us understand that and embrace that. I've oftentimes mentioned during other hearings, people say Guam doesn't have universal health care. We do. It's the Guam Memorial Hospital. Because you need care, you go there, you get it, you can't pay, everybody else pays, right? Anyway, so a lot of great detailed questions from our chairs and everyone else. So I just want to drill down to the bottom line based on, with a few questions of what I just mentioned. You could, I don't have the benefit of the request of last year other than what's been printed in front of us, but what subsidy did you get from the legislature last year in terms of general fund? Because as I'm seeing it, you're counting on revenue here of $3.5 million from general fund, and then of course leading all the way down to your ask, which is your shortfall over your 42.2. So what was the total general fund revenues that GMH received in 2022?
For 2022?
Yeah.
Okay, it's 3.5.
3.5.
3.5 million.
3.5 million.
Yep.
Okay.
That's it.
And then in 2023, so far, what has been your
3.5 million.
3.5? So essentially, and this kind of seems reminiscent of in the past when we've gone through this cycle of how many years we accumulate all the debt and all the obligations and the like, and then I'm just looking at this, and to me, there's really no other way to say it, but this essentially is, by and large, a shortfall and what GMH is coming before us saying what you need to operate, if you were to operate properly.
Yes.
See, because I look at the total of the budget, and for me, I think budgets should identify what are our priorities. I don't have a problem taking money from other places, but I think with this ask, and as you put it forward, I guess my next question is, and it was mentioned by our chair, there's quite a disparity between the request here that you have and the governor's request. Have you reconciled that with the governor?
No.
Okay.
No.
Because what I don't want to end up with here, and I'm sure our chairman and those on the committee are going to grapple with this, and we'll grapple with this in the global event that will be August when we all come back here and hash this out. But what we have before us right now really is, with this ask, if we were to attain this, there is going to be a significant adjustment to the current budget request that the governor has put forward and the current budget request that OFB is going to approve. And I'm saying this because of the fact that I want it firmly on the record that this is what GMH is saying that they absolutely need and require to operate at the operational level to complete its mission.
Yes,
Okay?
yes. All the divisions have come together, submitted what they need. We trim it down as much as we can, and really at the end of the day, it just came down to this. It was much higher before. It was much higher, but we had to trim it down and asking everybody really what is the absolute basic things that we need, and it came down to this number. Yeah.
Can I mention one other thing?
Yes, Dr. Prince.
I'm so sorry. This is what I was talking about in my first paragraph. I know I probably spoke too long, so you probably forgot about
Please.
things. But honestly, what you could just mentioned is our bare bones operational capacity, which is patients come to the hospital, they are sick, we get paid for that. This is what we're talking about. But honestly, we have a community responsibility capacity that goes above and beyond, as well as operations like with typhoon, knocks out everything, floods in the hospital, all these things that are not in our budget that we could attain for. So that's what I want to make sure that we're clear on. This 42.2 is really truly for the operational capacity.
And I appreciate that, Dr. Prince, because there's really no other way to sugarcoat this. I mean, there's no other way to we have got to, at some point in time, particularly with GMH and other critical areas, we've got to hold as much accountability as we can, but we have to also be true to ourselves that we cannot shortchange these areas. Because if we're doing that, then we're not meeting what our key requirements of a government is. And so I can't overstate the reason why I just want to focus on this issue. Because to me, if the committee is going to accept this as truth to form and veracity, and you've made it abundantly clear that this is what you need to operate as a bare bones operational number, then as far as I'm concerned, as one of 15, then this is the number you're going to have. And we're going to have to go in with the sharp pencil everywhere else and figure it out. That's my position. That's only one of many, but as all of the questions have been asked, the only thing I see floating, Yuka, and really in terms of the entire team here, Lillian, the only thing that I really see here floating is the ability for collections, both past and current. So the only thing that I can say really at this point in time is there's quite a bit of improvement with the 53% that's tracking. We'll pray that that tracks as well. And then do you have a committee, Yuka, that really just concentrates on the reconciliation and packaging in terms of the past due for the purposes of those requests coming forward?
Yes, so the billing staff is working on that. They've been working on it for the past maybe 3-4 months. We did get, when the network went down, we really shut down too. So that's part of the reason we're cleaning up the aging, is because once we get a good aging report, it gives them a tool to really track all the claims and know what's actually owed to us. It gives us a better picture of what our collections will be, where our shortfalls are as well, and one of the issues we need to do is automate more. There's a lot of paper still around too, so we're always exploring ways to automate more and make it less tedious so the claim can get faster, we can collect faster. That's a big initiative we're also pushing in our department.
Now, just as I close up here, I know that, there's always going to be, we also need to find pencil on the operations and go in, and we can do that together through quarterly oversights, or we'll call them roundtables. So they're designed to really be based on performance-based budgeting. But the reason why I'm leading to my final question that I'll ask the chairman to consider when we go forward is, because, as you said, Dr. Prinz, it's not an exact science, and we all know that it does float. Like I said, the Guam Memorial Hospital is basically the universal health care of Guam. Let's just call it for what it is. You don't turn anybody away. You can't turn anybody away. You don't divert like another hospital does or whatever else if revenue issues are a problem. So this is what we're doing here. So let's at least accept that that's part of this exercise. But the reason why I say that is because To me, I think maybe we can be a little bit creative here too in terms of the overall ceilings and how we're going to adopt ceilings. And maybe we partner with this, right, when we set strong goals for us in terms of collections, in terms of how we're managing that, and we kind of update that as we go through. Because we may be also, if it comes to balancing the budget, we may be able to float some of this as well, because those revenues should float. So maybe we do something like, we accept your 42.2, because even with storms and everything else, with all due respect, Dr. Prince, and I think your team is doing a good job. It's been in the media that you're hot on the trail to get reimbursements from FEMA and everything else to take care of that, but you got to float that cost as well. I get that part. But maybe we break this down somehow to say, we'll meet this halfway with appropriation and the rest will be authorization, and we'll track it. You know, we'll say, if that comes to, comes to the third quarter of the fiscal year, sorry, Gov Guam, with the rest of whatever else is going on, this is going to get paid. But I think that, depending on how we land in terms of what the overall reconciliation from the Office of Finance and Budget and BBMR, and when we get into the nitty-gritty, when we sit in here in the Committee of the Whole, I just want you to, I needed you to say that, look, guys, we need this money. If we're going to break it down and we're going to go in and we're going to start evaluating, division by division, we can do that in order to ask those questions. To ask you today right now and say, how come employee A is getting $95,000 a year with benefits? I don't know. That's not possible to do in this situation. But I think we can find a way to make everybody understand where we're at if we all have a consensus that we accept this number. But I'm saying, and I thank you for recognizing that, Dr. Prince and the team, saying this is a big ask, but I think we need to start really, really budgeting based on what are the priorities of our community and what are our needs. But also, because you have a revenue base, let's meet each other somewhere in the middle and basically say, we can take you on this 42.2, but we're probably, like I said, if the chairman accepts, I'll make a recommendation that we split that somehow if the ceiling doesn't meet when we actually get down to the nitty-gritty, saying, 21.1 is going to be your overage, and that's basically the difference between you and the governor right now, right, Mr. Chairman? I think that's what was broken out, that the actual real difference on the request right now is right around 20, a little bit over 20. And so we said, well, we're going to accept your number, and for the balance of the 21.1, we're going to say, we can make an authorization level, but we're going to sit down every quarter and go over where are your collections, what are you doing, what can we do more? Because if we can meet that, then we balance our budget out easier, and we see commitment on both sides. And I'm just going to propose that as an opportunity. Our chairman will have the final word, and the committee will, and we'll haggle over it in the budget process. But I want to stop going year by year by year by accumulating the fact that you're not getting what you need, and what do we end up with then again? If you look at the trend is there. Every 3 to 4 years, we end up having to go to the market somewhere else because your deficit is so big that you no longer can meet those requirements for your vendors and the like, and it's pay me now or pay me later, right? Yeah. So to me, we've got to make a decision that in our partnership, and I got to admit, COVID threw a wrinkle into everything. We just got to write off those years as being competitive and doing what we need to do just simply because we were, but then of course we had the benefit of the grant, so that leveled it out. But now that we're back to a true equilibrium again, where we're going forward without that hanging over our head, I think that if we develop a relationship, and because we could come in here and say, nice ask, and give you 10 more, give you 10 of this 42.2, but the roosters are going to come home. There's no other way around it. And we'll be going to the market, or we'll be slashing somewhere else afterwards, because of the fact that there's just no way to basically come to you and say, figure it out if you don't have the operational costs. So that's what I propose at this point. Maybe when you go back, you can, before we get into August, just work with your team a little bit more, work with the board a little bit more in terms of how you can say, these are some of our anticipated numbers, all things being wonderful, all things being moderate, all things being not so wonderful, but know that, at least from this, I'm just one person speaking. We got to help you, no question about it. But I think before we get to the final number, help us help you in terms of what you can do to exercise your commitment to realize and find some of this 42.2 as well. Dr. Prince?
Thank you, Senator Duenas. I mean, truthfully, that's absolutely correct. It's like, for me, it's like I have to be accountable with the people that I lead to the rest, right? We have to get more horizontal versus vertical, right? Vertical silos, that's a thing of the past. We got to get into horizontal, and we have to be accountable to one another. If we're not accountable to one another, and that's the thing is because when one entity is accountable to the other, what is desired is for the other entity to also be accountable. And that is actually truly as long as we have a path forward and we're all being accountable to one another, then it's a happy marriage. But it's still with the purpose of what the mission and the vision are, a shared mission, shared vision. That's the only way, because again, I have to make sure that those who are under me are accountable to me, but also I have to be accountable to them and lead with the servant leadership to move path forward. Thank you.
And that's what I'm trying to drive, Doc, because truly, like I said, we could have opinions. We could, like you said, you're right. I mean, you cannot compare Guam right now to just about any. Maybe you can pick a rural district somewhere, in the deep south or something like that, and maybe come up somewhere. But you don't have a jurisdiction where you have an influx of migrants from, a jurisdiction, a neighboring island, our family as well, but that have a whole different demographic in terms of their capabilities of paying and also the non-communicable diseases and the things that they present with. I say this because I know firsthand, I live with Ilkdagger. So I mean, I can appreciate, I know what happens. So I know that somewhere in here, there is the right mix and the right partnership. And that's why I say, I'm going to take you on your number, but I'm also going to challenge you to meet us, in terms of what are your efforts. And I think the community feels good too if they know, you're pulling the wagon as far as you can pull it. And then, we hitch up and help you pull the wagon. Thank you, Mr. Chairman.
Thank you, Senator Duenas. Senator Brown, do you have any comments or questions, ma'am? And don't worry about the clock. You're on.
Yeah, I hope not. Hopefully I'm the last one this morning. Thank you, Mr. Chairman, certainly to GMH for being here. And I know a lot of important questions have been asked this morning, but I did want to ask on your unclassified, and I know Senator Tello kind of touched on this, but what positions consume your unclassified? Because you have a number this year for 49. Who holds your unclassified positions at GMH? Well, so are we. We're all unclassified up here, but who is unclassified at GMH?
Sorry. Some of the physicians who we employ are unclassified status.
Okay.
Yeah. I'm trying to think who else are in the unclassified positions that... Us, we're all unclassified, absolutely.
Yeah, I don't notice those indications on your staffing pattern. I just see names and salaries. I don't see anything that tells me who is or is not.
Okay. And as I said to Senator Tello, I will get back to her with the details of it.
Well, if you can provide it to the committee so we can see it, because I am concerned. I don't know if it's the case at GMH, but I think we've seen a growing number of unclassified hirings throughout the government of Guam and department and agencies on positions that are being filled that are in the classified service that should not be hired by unclassified. And we're also seeing a number of unclassified that have been extended far beyond the 1 year that's been allowed. Unless the law has changed, I'm not aware of that. But, we're seeing a considerable abuse in some areas of the unclassified hiring because obviously they don't have to go through the hiring procedures. Okay. They are required to meet the credentials of that position, and they're limited to 1 year. And I'm just seeing it in the government of Guam substantially higher than I've ever seen it in ever. Mm-hmm. I mean, normally you have the director, a deputy in a department. You mentioned, of course, I understand your physicians that may be unclassified. But I'm seeing a number of positions that are existing classified positions that are being filled by unclassified individuals, and that really should not be the case. I think it's an abuse of the system. I mean, even though I question the credibility sometimes of our hiring practices in the government, even under the classified system, I don't think we should be encouraging the abuse of it. So if you could provide that, that would be helpful.
Yes, Senator. We will.
Guys did mention you're current with your payments. Are you current also with your vendors? I mean, historically, these have always been issues, but, and I realize the money has been flowing, and I'm going to bring this up as I do with every agency. The money's not continuing to flow. We're seeing the numbers of revenue coming down, and I'm not going to be surprised if that trend continues. I think that's expected. We went through the incredible infusion of federal money as a result of COVID. We see that's drying up, as you are with GMH, of terms of money to be spent there. And even though this typhoon's maybe given us a little bump, I think that's going to dry up as well. And I think we have increased considerably the cost of government, and I don't think the revenue stream is going to match up with that. So I think we're in for a little bumpy road ahead. I don't think things are going to be flowing as glowingly as they were, and the legislature hopes a little more cautious with the amount of money that it appropriates and authorizes. But where are you with regards to vendor payments, retirement payments this past year? Are you all current with that? To the retirement fund?
We are. It's our vendors that we're having problems with right now. So we do owe a significant amount to vendors. Our payables today is hovering around 24 million right now to our vendors. Yep. So that's where we're struggling. So I did have the slide showing where our cash has really been decreasing, and then of course our payables are going to go up because the cash isn't coming in.
And in those primary areas, what vendors are not being paid? I mean, of course, I'm sure all the services and materials and medicines and everything that you need are all important. But we don't want to keep the historical trend of where, we end up getting a bad name and businesses not wanting to deal with us because, they're providing us the materials or the medicines, the service, the equipment, and we're not paying for it. And we're back in the same old unfortunate situation. So how are you looking at addressing that so that we can, because they're the short, everybody's getting paid and, that's getting their salaries and everything, but then
yes,
without the
you're
tools
right.
and the resources you need to do the job, we're not in a better situation.
So we do owe a significant amount to our pharmaceutical vendors and our medical suppliers. Those are the ones that we owe the most to, and it's really, our priority is for payroll, and we pay we're up to date on retirement and all the other payroll payables that we have to do, and then the next is the vendors. So whatever
How
cash
far
is left.
time-wise are you behind? I mean, I'm sure it's all at various levels, but on average, how far are you behind? 90 days, 30 days, 120 days?
Some are 6 months. Some are 6 months.
That's substantial.
Yes. Some are 6 months. The travel nurse agencies, we don't even pay them now. We just wait until FEMA pays us. So we've been waiting. The wait game with FEMA is pretty long, but we do have weekly meetings with them just to keep them apprised of where we are as far as the grant coming in, and assure them that when that grant money comes in, they will be paid. So that's how we handle the amounts that we owe for the travel nurses. For the other pharmaceutical vendors, we try to make even small payments just to keep the accounts moving. We should be making larger payments, but sometimes they're okay with the smaller payments.
Are you in a situation where any of them are not providing any service or medicines or anything to the hospital as a result of the delay in
Yes,
payment?
we have credit holds.
In what areas?
I think mostly in the supplies and pharmaceuticals. There are some vendors that have put us on credit hold.
And has that impacted the ability of you to provide care at GMH?
We find substitutes and alternate types of medications if it's pharmaceuticals.
Well, I think that's a tight situation to be in. I hope you will update us on that, because that is concerning. I mean, if the vendors are always going to be left at the bottom of the list of priorities, this cycle doesn't end, and I don't want to get to the point that, especially there's only so many companies that provide certain services or goods. I don't want to get to the point that they just walk away and we're left, our people are left at the disadvantage of not being able to get, and nor your professional staff being able to get what they need to do the job that's most important that they need. Because any one of us, any family member of ours could be, could be the one at GMH that's at short end with regards to that. With your drug testing, What are your designated positions at GMH?
That's a very good question. We just had a BOT HR meeting last night, our HR administrator, working with the team to identify what positions fall into the TDPs, so that then we can proceed forward with the random drug testing with our
So that
policies.
would be safe to assume then that you haven't been doing drug testing then if you're just now
Not
identifying?
random. We haven't been able to do random.
On
but
your
now-
designated, just specifically on your designated positions, have you done any in the time you've been at GMH as the administrator?
Not as random, but we have done reasonable suspicion. We do regularly and consistently the pre-employment. We just also recently secured on a contract the MRO, because that's one thing that we didn't have either. It was an MRO. So now we have a contract for an MRO to then be reviewing those test results, especially the ones that are questionable. And so we are moving forward. I remember the question you had last year, and so we are moving forward with our HR team to proceed with that random drug testing because...
And I just bring it up. I mean, I bring it up every time, and it's a concern to me because we have such a big drug problem on the island. We all know. We're all suffering from it. We all feel that sense of lack of safety in our own community, in our families, when we leave our homes, when we come home. And I just want to make sure that those public officials that are working, and certainly in these critically designated positions that are providing care to our people, are not on illegal substances that could harm their ability to perform their job and harm others. So I would like to see consistency. I know there's a previous executive order under the previous administration that does require regular drug testing of designated positions, and we're not seeing that. I mean, even the Guam Police Department, yes, recently has started, but you know, when you have officers saying the last time I took a drug test was when I got hired 20 years ago, that is concerning because these are critical positions that provide or have authority or provide direct service to our people. So I hope by next year you can let us know. I mean, that's up to you when you want to conduct these, obviously, but I think we'd like to see some consistency with the designated positions to provide drug testing.
Yes.
With regards to, I know that the speaker touched on this, but I'm looking at the additional amount you're asking of $5 million out of the general fund. You know, we've had substantial, and again, I have run agencies. I understand the challenges that you deal with. I mean, you have increased costs inherently, even if you don't increase anything else. Insurance and other things automatically are going to go up, and I understand that. But at the same time, as I caution, when I see the decrease in numbers, you know, I'm sure you're going to have to juggle, and you're familiar with that, and your many years at the hospital of knowing that you've had to juggle to get by. Assuming that the legislature is able and the revenue stream shows you can provide that we could provide the $5 million. But your pharmaceutical fund, this significant increase from 19.6 to requesting 33.7 for fiscal year 2024. I mean, how do you see that amount coming to that level to accommodate what your needs are? And is there actually 33.7 million in the pharmaceutical fund to accommodate this request?
Was that a question, Senator, for
Yes.
us? Well, can you repeat the question, if I may ask?
Yes, I mean, you're having a request from this fiscal year of 19.6 under your pharmaceutical fund to increase to 33.7 million. I mean, is there 33.7 million or more in the pharmaceutical fund? How do you anticipate that this is the amount you're going to be able to get? Does it exist in that level? 33.7 million.
That's the amount that we need. Where if it's going to come from pharmaceutical funds, I can't say that. You know, that's not my decision to make, but we do.
I understand, but do you know what the current balance is of the pharmaceutical fund?
No, ma'am, I do not know what the current balance is of the pharmaceutical fund.
Okay, and if it doesn't add up to 33.7?
I
I would check. I don't know. We can check. I mean, I would check. I would want to know if there's that amount to accommodate, because otherwise it's going to be a substantial shortfall. Yeah. One other point I want to make, I know a lot of questions were already asked, but it was a concern, and I know Senator Tello touched on it with regards to the issue you had with the breach that she believes has happened at GMH, and probably question of degree, you could call it that. But as I mentioned then, and it does concern me how GMH responded. I know it's not budget related, Mr. Chair. I just want to make this one comment. it does concern me when the information provided to the public is not timely and accurate. I understand for your own reasons of investigation, and maybe, Senator Tom knows better than me because his background, this is right up his alley, but there might be certain things because of an investigation you might not want to reveal to the other party. But I think the need to ensure publicly that there's a level of transparency in the information you do relay is important. And during that time, I don't feel the information that was being relayed and the explanations that were being given out in press releases were being forthcoming with what occurred. There are ways to do that, and we understand there's certain information that can't be released because you might have an ongoing investigation. But I think it's important to be very forthright with our people because, you cry wolf and then the time comes, we don't believe you. And I don't like that sense of distrust. It's bad enough a lot of people already have inherent distrust in our government. But when we put it in black and white, and that's what we issue in press releases, it's very concerning. So I just want to bring that up.
Well, thank you for that. Yes, we certainly would like to, but we also need to make sure that, like you said, we protect the confidentiality, and especially if there's an investigation that's still going on. And at the time, if you're talking about the situation with the IT,
Yes.
at the time we needed to just really contain the information.
I understand,
because FBI,
but Lillian, I will point out the concern is when the information that is and was given out is not truthful, and there were other explanations given as to why there was a delay with regards to what eventually became known to the public. I'm just relaying, it's a concern, and that's something that your key people that do, including the authority of you ultimately in approving what message gets sent out.
Correct.
It's just important to ensure, even if you cannot, because of an investigation, outline the specificity of what has occurred, I think you need to give the public a general indication of what has occurred. And that was not, and it did not occur in what I saw in the actual Finno-English and writing in the press releases that were issued prior to what eventually became relayed to the public. I'm just bringing that as a concern. I mean, people just need to have some sense, and I think the continued distrust, it's things like that that, make us question. And whenever we can avoid that, I think it's in all our collective interest.
absolutely. But if I may, in terms of distrust, we save people's lives in that hospital. So if one media puts out information that may not be accurate or truthful, that's their call. We give truthful information and accurate information, and we save lives in that hospital. We do.
Lillian, I'm not
so
arguing
that's the trust and the
I'm
confidence.
I'm talking about press releases.
Well, but I
that-
appreciate if you as a leader
excuse
too
me,
can
Excuse me.
speak that.
I'm talking about press releases that were issued by GMH. I understand media can reinterpret however they choose to. I'm specifically talking about press releases that were issued by GMH.
Okay.
It's just something to be mindful, and all of us, I mean, like I said, some of us have carried that. I understand, it's a lot of burden to carry in the operations of an agency, but ultimately, you're the main person at this time for GMH, and it's a public expectation that we have, and I've been around the block enough to be in a position to make the comments I'm making, and I'm making them because I just think we all want to have a sense. I understand the important work that you do. I've been a patient at GMH. I understand the important work that you do. But when things like that happen, it makes people question. I question. And I just think that when it can be avoided, and in those cases it should be, we want to make sure when we're asking a question, we're getting the accurate answer. Even if you have an investigation, you can simply relay, I can't get into those details. We currently have an investigation. We don't want to impact that as a result, but we also want to let the public know. Because people had concerns. Is their private medical information accessible? I mean, those are legitimate concerns. Is my credit card, my payment, whatever, is that public information now? Because and nowadays they can get that information, and in a second it becomes world news. And so people have that concern. So I simply want to relay it. I appreciate the time and effort you've all put in coming here and presenting your budget, and thank you for the continued work that you do. With that, Mr. Chairman, thank you for the opportunity to ask questions and comment.
Thank you, Senator Brown. One question that was brought up, where would it be best to put a new hospital? Just a reminder, everybody knows I'm the one that introduced to build a new hospital. I never said where. Want to say Central? I think the only place that's known as Central is called Tizan. The belly button of Guam is Tizan. Plenty property there. If University of Guam has space, then great. But I say, you guys figure it out, come to terms, call the oversight chair, my vice chair, who happens to be part of the task force, come to determination and agreement where it should be and be done with it, because part of that clause was that we got to make sure we maintain the current hospital. So as you know, one of my colleagues brought up, we need to figure out the 42 million. Well, you know, your pharmaceutical fund is driven by 6.19% of the BBT, and maybe you could be watching out for whenever the CRE says we got some surplus, and whisper to us and say, hey, can you give us some of that? And the reason why I say that is because whenever there is money, I never hear from GMH asking. And you know, yeah, everybody else is asking, and you know, I'm only concerned because my parents love to go to GMH, even though there's really nothing wrong. It's like, and I'd always tease by then, you know, God bless their souls, they're gone. But I know a lot of folks at GMH. The employees do a great job. You survived. God bless your souls. You guys have done what you could do. But you know, like you said, COVID is gone. Typhoon came. Get FEMA to harden your infrastructure and get you, except post-COVID or even further back to when they first moved in. I'm just saying this because while the federal government is willing to do this, do what you can. Get what you can. And I know you're going to be applying for grants, and I hope for the best. Because I tell this to every agency is that there's hundreds of millions of dollars in grants out there. They're waiting for folks to say, I'm applying. And we can talk about what you do. I know what you guys do. I see what you guys do. I'm just hoping for the best. And I'm willing to support wherever I can to help you get the funding you need. But, you know, numbers don't lie. We're just going to have to work with whatever the numbers come that's placed on the table when we finally get to the floor. And we're just going to work it and tweak it and see where we can go. And with that, there's no one else to testify. I want to thank everyone for attending this hearing and for providing feedback and suggestion. Guam Memorial Authority budget hearing is now adjourned. It is now 11:57. And may God bless you, and please take care.
Likewise, and thank you so much.